And good evening, good afternoon, and good morning to all of our participants around the world. Thank you for joining us today, and a warm welcome to everyone. For the delivery of health and nutrition services, digital technologies are becoming increasingly vital. Digital health services have been found to improve care quality and coverage, increased access to health information, services, and skills, and encourage positive health behavior changes. Digital technologies, which are people centered, trust based, evidence based, efficient, sustainable, inclusive, equitable, and contextualized, can play an important role in boosting maternal nutrition services and achieving the health and nutrition goals. This is the ninth Maternal Nutrition Technical e-dialogue, jointly hosted by ICMR National Institute of Nutrition, UNICEF, and FOXY. The discussions today will help us to better understand how digital platforms work and what precautions we should take when designing and using them. I am Rajni Peter and I'll be your host today. We are thankful to our partner Site and Live, Dr. Kalpana and her colleagues, Srujit and Mathavika, for their efforts in putting this e-dialogue together. The participation and cooperation of our other partners, Nutrition International, Alive and Thrive, IFPRI, Society of Applied Studies, and Institute of Economic Growth, is greatly appreciated. If any of your colleagues are unable to attend today's webinar, the e-dialogues will be recorded and made available in the ICMR National Institute of Nutrition YouTube channel. Before we begin, let me also remind you to please use the Q&A box at the bottom of your screen if you have any questions. Please indicate if your question is directed to a specific speaker before submitting it. It gives me great pleasure to introduce Dr. Bharti Kulkarni, the Maternal Nutrition Series convener. Madam is the Clinical Division Department's head here at NIN. She is a Deputy Director and Scientist F. Maternal and child nutrition, anemia, body composition, and developmental origins of health and disease are among her key research interests. Madam, I will hand it on to you.
Thank you, Rajni. Good afternoon, good morning, and good evening, everyone, depending on from where you are joining. I'm very happy to welcome you all to the 9th dialogue in our monthly technical e-dialogue series on maternal nutrition, which is convened by ICMR National Institute of Nutrition and FOXY. It's truly heartening that our monthly e-dialogue series has completed 8 e-dialogues thus far since we started these e-dialogues in January 2021. And this has been possible only because of the wholehearted cooperation of all our partner organizations, including FOXY, UNICEF, Nutrition International, Site and Life, International Food Policy Research Institute, Alive and Thrive, Institute of Economic Growth, as well as Society for Applied Studies. These e-dialogues are woven into a common theme of strengthening maternal nutrition assessment and care. And many of you would have attended our previous e-dialogues, which dealt with important issues of public health importance in the area of maternal nutrition. We had these dialogues on maternal thinness, maternal obesity, maternal anemia, how women's groups can be leveraged for improving maternal nutrition. Last month, we had a very interesting e-dialogue on how social marketing strategies can be used for improving maternal nutrition services. So today we present to you yet another interesting e-dialogue on digital innovations for maternal health and nutrition. We all know that India is witnessing a digital revolution with deeper penetration of mobile phones, and this has opened up enormous possibilities to improve the reach of diagnostic services as well as delivery of healthcare services to the underprivileged. So we are very fortunate to have eminent speakers and panelists with us today who will be sharing their experiences in the area of improving maternal nutrition through digital technology. We are also honored to have with us today Mr. Osama Manzar, who has kindly agreed to chair today's e-dialogue despite his busy schedule. And I'm very thankful to Mr. Manzar for being with us today. It's my privilege to introduce Mr. Manzar, who is the founder and director of Digital Empowerment Foundation. He is a British traveling scholar and a US State Department International Visitors Leadership Program Fellow. He is a social entrepreneur, author, columnist, impact speaker, and he is a part of several government and policy committees. We could not have a better chair for our today's e-dialogue. I would now request Mr. Manzar to give his opening remarks. Over to you, Mr. Manzar. Thank you for joining us today.
Hi, hello. Thank you very much, Dr. Kulkarni. And great to be here and great to see there is a lot of participation here. We have already more than 80 people I can see on the participant bar. So obviously this topic that we have chosen to have an e-dialogue on is important to the sector and to everybody. I don't know if I deserve to chair this session, but Dr. Kulkarni's insistence, I can only, bring in some of my experience, and I'm really looking forward to learn from the panelists, many of whom I know personally. And so the couple of minutes that I would like to say here is that, for any topic that we choose where we digital play a role, it should not be dominated by digital in designing that. That's very, very important. We must not get driven by the overwhelming digital and its overwhelming necessity in our life. What is very important is the topic itself. We are looking for nutrition. We are looking for prenatal, postnatal, and related issues. We are looking for women involved there. These are the most important part. And in this most important part, we are looking at the bottom of the pyramid. Our women, our nutritional issue, and this entire health-related issue is at the bottom of the pyramid. Where it is important? Village level, block level, panchayat level, tehsil level. That's where it is very, very important. And when we look at those level, we need to figure out what is the role of technology in making all the roles around that important and efficient. That's very, very important. So we are not looking at technology here for the sake of technology. We are looking for technology here for the sake of, number one, communication. Number one, dissemination of content that they deal on a daily basis. Number three, the availability of expertise and information at the click of a button without being challenged in terms of language, in terms of medium, and in terms of messaging format. That's very, very important. We cannot say that we want to make the whole cadre nutritionally empowered, but for that you have to learn ABCD, then you have to learn keyboard, then you have to learn broadband, then you have to learn how to deal switching off and switching on. No, we need to figure out how technology can be them rather than them can be technology enabled. That's very, very important. Then only we can get a success. If we think oral oriented mobile device with a click of a button or a touch is more convenient, so be it. If emojis are more important, so be it. If the video is more important, so be it. If the oral podcast is more important, so be it. If not physical but digital archive to refer the problem is very important, so be it. If WhatsApp works better than a browser, then WhatsApp is better. I mean, nothing doing. We are not going to dislike WhatsApp because it gives you that orality of communication, which is very, very interesting for our people. People communicate these days not on email, but they send voice messages, they send video messages. They would like to understand by putting a kind. I have seen this shepherds and the grazers in the villages having earphone in their in their ears, and then वो चरा रहे हैं, बकरियां चरा रहे हैं और भैंसे चरा रहे हैं. I have seen those. I mean, they did not learn technology. They found it convenient to have entertainment while doing what they are doing, but they look like HEP English medium college students, sitting on a door of a library and doing hip hop, uh, but because that is oral, because that is in their language, that's why they like it. So we need to really figure out, and I was talking to informally Dr. Kulkarni the other day when we did the portion thing with digital intervention. We realized and we gathered that communication system through a big display in a village crossroad or in somebody's house in the evening while they are eating or relaxing is much better way to communicate than mobilizing them to bring them to a health center and then trying to tell information. So this is very interesting that we need to humanize the technology to solve our problems rather than technologize our humans. So that is the message that I would like to give, and I would like to stop there by saying that let's discuss today how we can make technology social, behavioral, and humane to adopt to solve the problems of nutrition and the messaging of nutrition and the expertise of nutrition in the hands of the people who are working on the ground as cadre to make our next generation healthy and hearty. Yeah, thank you.
Thank you, Mr. Manzar, for putting it very nicely that we have to humanize the technology and we should not lose sight of our core objective, and we should not use the technology for the sake of technology, but we have to make it work in the way it can work for our target population. Thank you so much for setting the scene for today's e-dialogue. I hand over to Rajni now for the further proceedings.
Thank you so much, Dr. Bharti. We have one presentation today, and it is my privilege to introduce Mr. Shrujit Lingala. He is Manager Technology and Entrepreneurship at Sight and Life Foundation and leads nutrition and livelihood projects that improve nutritious foods in low and middle income countries. He has a master's degree in public administration from Columbia University and MBA from IIM. Shrujit will present a review of digital innovations for improving maternal health and nutrition. Over to you, Shrujit.
Thank you, Dr. Rajni. I'm just going to share my screen. Please let me know when you can see it.
Yeah, we can see it now.
Great, excellent. Hello and good evening, everyone. Thank you so much, Dr. Kulkarni and Mr. Manzar, for that very inspiring opening remarks. I'm very excited today to present a landscape analysis on digital innovations in maternal health and nutrition. And what Mr. Manzar said resonates very well with me and the course of this presentation. I phase the next 25 minutes into three parts. First, we're going to look at the challenge areas in maternal health and nutrition. Second, we're going to look at the digital innovations which are addressing these challenges. You'll get a more nuanced understanding of what the innovations are and how they're working from our esteemed panel during the discussion. And third, we'll also explore what are the drivers that are enabling these digital services to be a force multiplier. And how are these drivers going to help us reach every beneficiary at the last mile, both effectively and affordably? So we've looked at the innovation landscape from the lens of the maternal journey, all the way from preconception, antenatal stage, and the postnatal stage. The innovations and the analysis that you will see further in the presentation is going to maintain this particular structure. Well, providing holistic maternal health and nutrition support, especially at the last mile, I'm sure you're aware, is fraught with major challenges. And we've been able to condense them into three specific areas. First is there's a clear lack of awareness, motivation, and adherence towards positive behaviors. And this applies not just to the woman, but also the family and also being able to support the health workers. Second is a lack of timely diagnosis and monitoring, which results in delayed decisions. And third is the difficulty in making the products and services available in hard to reach locations, which is the last mile. Let me unpack these challenges to you one by one. First is deeply entrenched norms. Positive attitudes towards maternal health and nutrition are not really reflected in the community. And this is because of deeply entrenched traditions and norms across multiple levels. We can talk about gender. Pregnant women in the communities have very little decision-making power when it comes to their own health. Attitudes and behaviors, and people tend to have a chalta hai attitude towards nutrition unless it is life-threatening. So much so that conditions like anemia, diabetes, and hypertension are so normalized to the extent that most people believe that it is part of being a woman.
रेशमा का क्लिनिक है?
हाँ, डॉक्टर रेशमा का आपको कांटेक्ट मांगता है?
नहीं, वो है नहीं क्लिनिक.
Yes, I guess there's been some disturbance. Okay, great, thank you. Then, as I was saying, attitudes and behaviors, there's a normalization almost to the extent that people believe conditions like anemia, hypertension, and diabetes are normalized. And people believe that it's quote unquote part of being a woman or growing old. The third is traditions and customs. Nutrition is closely linked with local customs and beliefs. And it's important to engage not just the pregnant women in this case, but also the entire family. And the fourth is the short-term incentives. When we're looking at changing behavior across communities, it's linked more often than not with immediate value identification. For example, unless a beneficiary and her family see short-term gains as a result of the behavior change, they're not really going to be motivated to comply. The second bucket and the second challenge area that we're looking at is delayed diagnosis. Timely diagnosis and interventions, as we all know, have the power to prevent critical risk factors in maternal health journey. But it is lacking due to insufficient or late antenatal visits. So much so that only 1 in 2 women in India completed the requisite antenatal care visits. And this causes challenges in starting pregnant women on relevant timely interventions. Unfortunately, the reason for this is not trivial. What happens on the ground is, given the real need for income, for a woman or for a family, every day lost is a loss of daily income. And most women therefore work till the last month of their pregnancy in labor-intensive occupations. And therefore, such financial compulsions, they limit the woman to miss a day of work to travel to a PHC for her test. And therefore, she just cannot afford to travel a day, go to the clinic, wait to get the test done, come back from the clinic, so and again go another day to collect the results. So that's just not something that she can afford to do. And the third bucket is the logistics bucket, which is reaching the last mile with affordable and accessible nutritious basket of goods. India is right now much ahead of its neighboring countries in terms of designing robust and holistic health programs. However, availability of ration, nutritious basket of goods and supplements, also medical services at the last mile still remains a concern. And cost of distribution, the main reason for this is that the cost of distribution through traditional channels, your Kirana stores or any other retail channels to reach these remote locations is prohibitively high. And as a result, what happens is in low income settings, either a nutritious basket of foods is not available or we find substandard quality counterfeits. where in fact there is actually a huge demand for affordable but also high quality products. Great. Then, so that brings me to the solutions and actually the snapshot of the landscape. Here, what I've done, you'll see, is I have bucketed the solutions across the 3 challenge areas, and you'll see the solutions structured according to also the stage of the maternal journey. In the awareness section, I'll take you through some of the interesting solutions that we have also been able to unearth. In the awareness section, the need to engage pregnant women and her family on be it the role of nutrient-rich foods and the importance of reaching out to health workers is extremely high. And in terms of diagnosis, analysis, and monitoring, efficient and affordable, in fact, point of care testing devices, which can be used to treat the patient in the fastest manner possible. Being able to do this will support the timely diagnosis. It'll reduce patient waiting time, and it'll lead to fewer days when the pregnant woman or the lactating mother has to lose income traveling to hospitals. And also applications which help and enable frontline health workers to make quick, effective decisions are also very important. And they help all of these innovations, specifically in the diagnosis and analysis and monitoring area, help cut that decision-making time and provide the timely intervention. And finally, using technology also to simplify last-mile logistics will make these high-quality products and services more affordable. Before I go to the next slide and give you a snapshot of all of the innovations and the cutting-edge organizations that are doing great work in the space, I just wanted you to take a step back, probably take a minute and think a little bit about the digital innovations. You must have come across a few digital innovations which you think have addressed maternal health and nutrition. I'd like to open a poll, if that's okay, Dr. Rajni, if we can just get the first poll started.
Yes, sure. So you will see a question on the screen and you have one choice to answer. Like you have to pick one choice from the options given below.
Yes. So we are interested to know how many digital innovations can you think of that address maternal health and nutrition? And once you finish submitting the poll, please also do enter the innovations that you can think of in the chat box. It'll be very, very helpful for us to gather all of these innovations. I'm pretty sure in the next slide where I show the innovations, I would have missed quite a few of them, and your help will be very useful. Great. I'm already seeing a few answers coming in. Arman, Raj pushed IEC Baby Center app. Yes, chatbots are extremely important.
Yeah. So almost 50% of the participants have voted. Can I end the poll now?
Yes, I guess we can end the poll.
Yeah. So these are the results.
Oh, great. So most of the participants, around 50% of them, have been able to come up with one or two digital innovations that they have in mind. And 18% have been able to come up with more than 5. Please, again, I suggest you to please put the innovations that you're thinking of in the chat box. It's going to be extremely helpful for us and also for the other participants to see what these innovations are. Great. So again, you've seen that now we've seen that the premise and the framework of the digital innovation landscape has been set up. What you see on the screen is a snapshot of all of these innovations we've identified across buckets. As you can see, there are quite a few organizations working across each stage of the maternal journey, and they have been tackling each of the challenge areas. About 25 are listed here, and I'd have loved to take you through each one of these innovations. But in the interest of time, I will limit myself to 3. But also in the panel discussion, we are also extremely lucky today to be able to hear from these experts in many of these organizations, which in fact are actually featured here. I'll leave the slide for a little longer for you to take a look at what these organizations are and if you're able to identify any of them. Great. Let me start with an organization called Nura Health. Nura Health was started in 2012, and it aims to solve the first puzzle piece that I talked about, which is the lack of awareness. This organization was set up from a very simple but deep insight that in India, when patients visit a hospital or are admitted in the hospital, there are usually family members who have a lot of motivation to support the kin, are wanting to do anything possible to be able to support the patient, but they're not very equipped to take care of them. So what Nura Health's Care Companion program does is it involves these family members to contribute to the quality of care. And how it does is by disseminating relevant health information through simple digital platforms. It doesn't do an app like how Mr. Manza suggested. It's what works best in that context. It uses digital platforms such as text, WhatsApp messages, and reinforces these health behavior changes and connects them with the medical practitioners. Started in 2012, Nura Health is right now in 6 Indian states and in Bangladesh, and has reached over about 1 million family members and has been able to train them. Next is an organization called HemoCue, which started in 1982, and it aims to address the second bucket that I was talking about, which is diagnosis. HemoCue enables timely, efficient, and reliable diagnosis across all hospital facilities. And how it does is it does this through small and portable devices that we can screen and it's point of care devices. Through these devices, we're able to screen and we're able to monitor areas and lifestyle diseases like iron deficiencies and diabetes. And this makes them ideal for use on the field. It does not require only a hospital to be, kind of like being testing it. It can be tested on the field or even in mobile care centers, which are reaching the last mile. Then the next organization I wanted to talk to you about is Hessa. And this one solves the third bucket that I was talking about, which is accessibility at the last mile. And Hessa solves this problem through an interesting mix of both digital and physical. It has a village level partner or resident whom they call the Sathi. And this Sathi or a friend uses this Hessa's digital platform to communicate, order, and sell a basket of goods within the village. And through their B2B digital platform and physical presence of the Sathi, Hessa allows for the products and services to reach rural parts of the country. And it does so with very, very minimal capital investment. And Hessa reaches about 700,000 rural consumers in 5,000 villages, around 11 districts in Andhra Pradesh and Telangana. And it started just in 2019, right before the pandemic. These are the 3 organizations that I wanted to throw a quick light on, but you'll also hear, like I said, about 6 other cutting edge digital innovations during the panel discussion. I'm really, really looking forward to that. Now, COVID has accelerated the digitization wave in every walk of our life. And as we analyze the landscape, it's very, very clear. It's becoming more and more clear that there are huge shifts that are going to happen, which are very imminent also in the maternal health and nutrition space. So then I thought it would be good to also look at and explore what are these drivers that are steering us into this new future. First one is enabling environment. There's an increasing trend, as we all know, in mobile penetration in the country, which will mean a wider reach and access of digital services. However, we need to be also aware of a nuance here, which is the gender gap in terms of mobile ownership, especially in low and middle income countries. That actually brings me to the second poll. Dr. Rajni, if we can open the second poll.
Sure, I'm launching the poll now.
Yes, thank you. Yes, like I said, India is, mobile penetration in India is very high. In fact, in India, 75% of men own a phone. What percentage of women own a phone? If you don't know the answer, feel free to take a guess.
I'm going to close the poll now and show you the results.
Yes, please. Oh, wow, excellent. Around 44% of us, we voted that 51% of women own a phone, which is true. Around 24 percentage points lesser than men's ownership. That's a nuance that we need to understand specifically in the maternal health and nutrition space. There are, on paper, a woman might be able to make a phone call when required. But most of the time, she also shares that phone with her husband, or in fact, the neighbors of the household, the neighbors along with whom she's living. And when we're trying to reach out through digital platforms, we might be thinking, oh, mobile ownership is at 70 or 80%, but maybe the women whom we are trying to reach, the reach is much lesser. But that said, there is a double-digit growth in mobile penetration, again, in rural communities. So that is a silver lining, definitely. Another driver is the fact that femtech as a sector is growing. And the good news is that pregnancy and nursing together account for 25%, the largest aggregated subsector. So there is an enabling environment for this change to happen. Second is an inadequate workforce. Healthcare workforce in India is inadequate, both in the public space and the private space. The fact that health workers need to be more efficient with their time is something digital innovations can play a huge part in. The right kind of digital innovations and tools can aid their decision making. It can equip them, it can empower them, and also add value to them. The third is community building. Creating a family buy-in and a sense of belonging within the community can be extremely strong drivers to adopt a technology or even a product. Think of the last time that you adopted a new technology. Most often than not, at least for me in my case, is because I know somebody who has already been on that technology and has vouched for it. So having a network is extremely important to be able to increase that mobile, not mobile, but digital innovation adoption. Second, engaging local champions and partnering with them to deliver products and services like how Hessa does, in fact, promotes credibility and adoption within the community. And third, user-generated content. When we're talking about awareness, user-generated content from the communities, whether it is for awareness or training, it is more likely to be adopted and therefore leads to better acceptance rather than when it feels like it's coming from outside. Another driver is frugal and flexible innovations. Innovations that leverage existing platforms like a WhatsApp or a Facebook, or those that use very rudimentary tech interfaces that beneficiaries like can adopt easily, are appreciative of. That's what will drive large-scale adoption. Applications might have complex algorithms and procedures in the back end. That's different. But what I'm talking about is its ease of use, its simplicity, and ability to also access innovations on various different platforms is another factor because of the sheer number and kinds of devices that we Indians use. Some people might be more comfortable with a feature phone. Some people might be comfortable with a smartphone. So if the intervention is delivered through various different platforms, it's just more likely to be adopted. And the last driver here is public policy. Currently, there's a rare window to take these innovations to a large scale and aid their integration to the public sector. In fact, the Indian government is quite committed to see digital innovations adopted within the government channels itself, promoting interoperability between various platforms, promoting digital privacy, and also enabling a platform where such innovations, in fact, can be adopted. So what you see here is basically a summarized snapshot of all the drivers that I talked about and can aid adoption. And that, in fact, brings me to the close of the session. And I would like to leave you with one thought. Let's pause and let's just look around ourselves. Digitization is everywhere, from social media and navigation maps to mobile phones, which are counting calories, robots, which are fighting climate change, governments, which are forecasting pandemic waves using Google. Our society has been transformed in many unprecedented ways. And the ongoing revolution is increasingly shaping how we create, how we think, how we collaborate, both at an individual level, but also at an institutional level. And this, I feel, is a rare window of opportunity for all of us, enterprises, social enterprises, governments, and entities to harness that global revolution and support our women of reproductive age, pregnant women and lactating women, and reach them more efficiently and effectively. Thank you.
Thank you, Mr. Shrujit. That was an excellent presentation. Thank you for giving us an overview of where we are in India in digital health, and also in highlighting the importance of enabling environment, the acceptance of the digital technology by the community and the healthcare workers, and the policy implications of all that. Thank you very much. Thank you, participants, for your attention and participation in the polls. Let us now proceed to the panel discussion. As usual, we have the outstanding Dr. Hema Divakar, Vice Chair of the FIGO PNCD Committee, as a moderator. Dr. Divakar is also the Medical Director of Divakar Specialty Hospital, Bengaluru, and a Senior Consultant Obstetrician and Gynecologist with more than 3 decades of experience. And it's my great pleasure to invite you, ma'am, to moderate today's panel. And a small, information to the group, to the participants. If you have any questions to ask Mr. Shrujit, we will be taking all the questions together at the end of the panel discussion. Thank you. Over to you, ma'am.
Namaskar. Thank you, Rajni. And Surjit in his comments said, pause and look around. And what do we see when we look around today? 8 stellar speakers who are participating in the panel discussion, which is just about to begin in a few moments, brought to you by all the collaborating organizations at the 9th e-dialogue. Talking about the figure 9, we have Dr. Rishikesh Pai and Dr. Aparna Hegde, who are the OBGYNs. For them, 9 means to deliver. So here we are delivering digital innovations for maternal health and nutrition. Let me very, very briefly introduce all our panelists, and I would prefer to give more time for them to reflect on their journey and take us through the challenges, the opportunities, the excitement, the lessons learned, etc. Because what they have done for decades, we are asking them to recap in a short span of 8 to 10 minutes. That's a challenge indeed, but I'm sure that we will be excited to learn a lot from them. So our panelists for this evening are none other than Dr. Rishikesh Pai, who is stepping into the prestigious post of the president of HemoCue in the year 2022. He's a pioneer in IVF and the director of the Bloom IVF Group. Great academician and published very many articles. The next speaker will be Ms. Sagai, who is the CEO of BB Chakra and the co-founder and president of MyGlam, the graduate from Harvard Business School and a Bright Scholar with Fulbright Scholarship and J.N. Tata Scholarship as well. We will hear a lot about the foundation that she has established and what the digital modality is delivering. My very beloved friend and colleague, Dr. Aparna Hegde, who was one of the first to take on to the reach in the nooks and corners of our country through the digital platform, the founder and managing trustee of Arman. She is a urogynecologist, but beyond that, many, many facets to her profile, being a social entrepreneur, researcher, and a TED fellow. Little Flower Augustine. This is a consultant at the ICMR NIN and a researcher in nutrition with many publication and research projects. And you will hear more about her work as we go along. Next, we have Dr. Archana Sarkar, who is the advisor and research and the M&E India, Food and Nutrition Security, Enhanced Resilience at GIZ, expertise in public health, nutrition, and anthropology, has a lot to deliberate on what we as the stakeholders and the clinicians group should be doing. By Shelley from the C4D, the specialist UNICEF at UP, expertise in scale of application of transformative and inclusive C4D strategies. The list does not end there. We have Dr. Anurag Chaturvedi, the Senior Program Officer from the PHFI, with great expertise in program implementation. Because, ladies and gentlemen, when we are talking about digital innovations, it is all about innovations to implementation. The gap between knowing and doing, which these great stalwarts have built and made things happen and transform their dreams into reality. So we'll hear more from them. Last but not the least is Shantanu Pathak, who is the CEO and co-founder of Care Mother, with interest and expertise in innovation, wireless communication, m-health, wireless healthcare, etc. And as the chair for today, Osama ji said, it's high time that we married healthcare to technology, and in a marriage, there is so much complexity and so much to adjust. So any which mode of technology that can reach people, here we are to do our best and bring in the humane element as well. So if you can just stop sharing the slides, and I see my right panelists on the floor here. I begin with Dr. Rishikesh Pai. The topic that was given to us, Rishi, is very, very interesting. It says e-Manyata. Manyata, for the information of all our delegates, is a flagship program of FOXY, our parent organization with 40,000 gynecologists. And I said, Rishi will be at the helm of affairs in a few months from now. When we started the Manyata initiative, which is all about delivering quality healthcare, delivering safe maternity care with quality, dignity, and safety. Dr. Rishikesh, when we started, it was not e-Manyata. It had nothing to do with the digitalization. But as we have evolved, now it is entirely in the digital space. Whether it's the skill transfer and training, it's digital. And whether it's assessment for accreditation, we say go digital. So how has this transformation come about, and what does it bring for everybody on the table? Dr. Rishikesh Pai.
Thank you, Hema. First of all, I would like to thank you for inviting me for this August panel. And I would like to thank Dr. Bharti Kulkarni, Dr. Rajni Prita. And, I was really impressed by Dr. Sujit's talk. I learned a lot of new things. Actually, I'm getting a little bewildered because there are so many, parameters and, variables, and so many people are there in this space of health provision. So, it's a great thing to know that so many people are actually, contributing to the healthcare industry in the country. The only, sometimes I would like to take this opportunity and this platform that we need to talk more together, see where we can have our capabilities and where we can have a convergence, you understand, because so many people are doing the same thing in different space. I don't know also, like for example, today Sujit told me about so many things I've never heard of them also. And when you are talking about a 1.3 billion population and then various programs doing impact of 1 million, 2 million, it has no relevance. So we have to all come together and the vectors have to get aligned. Otherwise, how will country benefit out of such fantastic and innovative programs? So somewhere we need to all come together and interact more often so that we can converge and we can have a more specific pointed program, right? So many people. So this is my first
I'm
submission.
glad that in the leadership position you have placed this as your first thought of connecting and collaborating. Thank you,
Right.
Rishikesh.
So the second thought is that if we just implement nutrition, it is a fantastic thing, most important thing in our country. But if we do it singularly, it will not work. We have to do it together. So if we take women's health, everything convergence has to be together. So the 10 or 12 important aspects of women's health, if we all implement them together as one platform, then we may reach a lot of people. The third thing which through my Sushit I've learned today was that 325 million people are without a mobile phone. So mobile is not the only. See, my dad was in family planning and he was in public health, Dr. D.N. Pai, and he always told me, because I was a child, when he used to go to the community. So we have to, at some place, we need to reach out to the community. The digital is not going to give us that final approach. There is always going to be that gap, and for that gap we need to step down from our apartments and from our computers. We have to go to the ground level at some point in time. So digital is important, but probably a hybrid model where we have a digital and a community involvement will be a better model than a pure digital model, because in digital people have to access that information. And so the fourth thing I think is advocacy has to be on a massive scale. Like when my dad used to advocate family planning, it was a massive scale. So we need to advocate health on a large scale. It can't be a minor advocacy. It has to be in the eye advocacy all the time, on television, on various big channels, not on Rajya Sabha TV, but on Colors channel. So we need to have where the eyeballs are. So coming to Manyata program, Manyata program is a fantastic upgrading program. And when the COVID started, before that we used to go and do the QA, QI and all that at the ground level. But with the digitalization, we transformed ourselves, we adapted ourselves to the change. And it's a fantastic thing that what happened is actually it accelerated our program. Yes. So we did everything, we trained them on the digital media, and at the same time, the different other medias like Zoom and Google, so many other Cisco's platform, all of these platforms came together. And because of that, we could actually transform the program from an interactive community program to a totally digital program.
So, Dr. Rishikesh, how does it feel? You're sitting in Mumbai, but you have a center in Delhi, which is now called the Manyata CSE, which is Center for Skill Enhancement. And you have your whole workforce, joining hands from various places, but getting the skills out there to the last mile.
Right. But so here this is what Dr. Pai thinks like. So I wanted to involve everyone in this program. So I said, okay, let me call all these gynecologists and let them give talks and all in the program. But I also, whenever they do give a talk, I still send them the bouquet of flowers to their house, because that is very important. So we have to not lose the human touch. The digitalization has to be bridged with a human touch, and together a hybrid has to be created to implement policy.
Okay. And if you think that Manyata is largely in the private sector, but private or public, wherever the woman is going, she has to get the minimal desirable care with safety.
Yeah. And Hema, before I sign, Ms. Logo, I would like to say that with your interaction, so next year, as a president of the federation, incoming president, my slogan is technologies transforming women's health. So there are huge amount of technologies that are coming in at a rapid speed, and I'm going to catch all of you here and bring you to the platform, because you have so much knowledge, you have so much experience. But the clinicians, so if you look at NDTV, then they have these programs on various Save the Tiger, Save the Swachh Bharat program. They don't call Foxy. Foxy is the implementation arm. Please understand, the ultimate interaction between the patient and the doctor is the gynecologist, or let's say the doctor, maybe even an MBBS. But that implementation arm has to be utilized by all of you. You have to all the time think that implementation arm has to be exploited. You need to exploit us. We are available for that exploitation, because then only whatever you do will be integrated and effective.
So we are holding Dr. Pai to his commitment that we are here and we are here to do our best, and we will stick our neck out and do whatever is needed because Dr. Pai, one last comment before you leave. Manyata program. If you go in person, on-site training, on-site assessment, we could do a couple of hundreds.
Right.
But after the digital platform has been exploited to its fullest, we have managed to reach a couple of thousands. How do you think the scale vis-a-vis the quality of whatever we do, how do you see that it's in balance?
So I think that scale, there's no doubt that with the digital Zoom, we will have the scale. So I think that we will be able to scale up the program very rapidly. Quality also, I feel that we should have hybrid. So maybe one visit at some point in time, or even, because I got so excited now because this can be applied to every aspect. Just the other day, 2 days back, I was telling someone that, sex education. For example, you go to school, it was always awkward, right? To talk to children, or they used to ask you questions. Teachers were awkward, principals were awkward, parents are awkward. I told the sex education chairman, I said, make a digital program. That's it. Let the kid access it. Total digital. So the digitalization has, has given us so many new innovations that we can apply in our day-to-day life. So it's a very exciting time, and we'll see how it works out or how it unfolds.
Yeah.
And the last, before I leave, I think the most important, what is the most important tool in empowering women in our country? It is the men. We have to catch the men to empower the women. In the women, there's a MEN also. So we have to use, because look what Sujit said, 75% of men have got the phone. We need a person like Aparna Hegde's Arman has to attack the men's phone, not the women's phone. Because the men also, unfortunately, in our country, where it is a man-dominated country, unfortunately, but it's evolving, it is changing. We need to attack the men so that they protect their women.
Thank you so much, Rishikesh Pai, for your time, despite your very, very hectic schedule and the thought process which is incubating in your mind for transforming our organization through technology in a few months to come. And you have touched upon the ground realities, the need to do a hybrid model, the opportunity to scale, and you have also placed the gender lens where we are in touch with the reality that yes, we need to work on that aspect as well. But Manyata initiative, which has done very, very strongly to the supply side. That means empowering the healthcare workers and the teams in the private hospitals, the frontline healthcare providers, who are now competent and confident to conduct the deliveries with safety.
Yeah, one last thing before I leave. When in my tenure, I'll be right on the streets with the community all the time, and I extend a hand, and I need a helping hand from all of you, that we need to get down to the community level and aggressively promote, advocate, and give them access to the program, whatever, nutrition.
Yes.
We need to advocate. And advocate. That is the key to success.
Thank you so much. Thank you, Dr. Rishikesh. We now move on to our next brilliant panelist, Naya Sagi, who is the CEO and founder of the Baby Chakra. I'm aware, Sagi, that you have to leave in a few minutes from now, but we would like to, we're very, very eagerly waiting to hear from you. The chakra, what does it do to all of us? Yeah.
No, so first of all, thank you so much. I was listening into Dr. Pai, and as always, he's an inspiration to all of us, as are so many of the other panelists have had the privilege of meeting, I think, in many interactions in the process of, building out the mission of Baby Chakra. And of course, Dr. Hema, it's a real privilege to meet you. Hi, Dr. Pai. It's a real privilege to meet you as well. So, the way I was thinking is that there might be many, panelists as well as audience members who may be new to Baby Chakra. So I'm going to spend the first 5-7 minutes introducing Baby Chakra, if that's all right, Dr. Hema. And we can open it out for questions or any sort of feedback, insights, suggestions, right? And of course, I think the whole idea of this, I think, absolutely incredible a set of people coming together who are so passionate about maternal and child health is that, how do we sort of collaborate together, right?
Right.
So I think that's what I'm really excited about hearing from.
Maggie, you would like to share your slides?
I will do that right away.
Yeah.
Am I able to, how do I share them though? Hold on.
You have
And
a
in the
button at
process
the
of that,
bottom of
tell
the
me
screen.
how the thought process began.
So, what I can do, so I'm happy to
Yeah.
tell you that. I'm just trying to see why am I, okay, share screen, got it. Sure.
Yes.
Give me one
Yes.
second, please.
Sure.
Okay, so somehow for some reason, I'm not,
Rajni and team will help you otherwise.
yes, let me do this. Let me just share it with Rajni.
Yes. If you can send it to us, like we can share it from our end.
Sure, let me just do that right away. Rajni, I'm just sending it to you on WhatsApp if that's okay. It's a Google presentation. Okay. All right. So, I mean, just as context, Dr. Hema, since you were asking how did the idea come about in the first place, right? There's a bit of a background there. I am actually what feels like another life altogether. I used to work in public health, but in consulting. So, I worked at McKinsey and Company where I was working in the public health practice, specifically in maternal and child health. So, I had and after that, I worked for about a year in the Public Health Foundation of India on secondment. So for about 3 years of my life that is when I got inducted into public health. And I think, in maternal and child health, I think there are some very interesting problem statements to solve for, right? First of all, of course, it was an area I felt most passionately about being a woman myself. And I think just interacting with a lot of stakeholders on the ground, a lot of women communities, a lot of practitioner communities as well on the ground, as well as sort of getting a landscape, right from the ICDS to WCD to talking to Foxy to IAP, right? To,
Yes.
I mean, to this whole bunch of bodies. Everyone is so, mission driven. So sort of collaborative. And I think everyone's trying to make an impact. And, my question to me was, how do I make an impact, right? Where can I play, right? So I think that is really where the idea of Baby Chakra initially started taking shape because, I went on to business school at Harvard, and in fact, my essay to Harvard was like, how do I come back to India and build out a digital solution and a digital platform for parents in India, for mothers in India? Right, that was literally my statement like 10 years back, right? And that's been my mission since. So that is how the idea came about. But there are a couple of broader trends I want to talk about, right? And I think those are what really inspired me. So if you look at okay, so there you go. So you have it.
Yes.
Thank you so much, Rajni. You're amazing. So if you don't mind, we can just go to the first slide.
Yes, sure.
Thank you. So yes, I think this is just a bit quick of a background to Baby Chakra as well as to myself. So I think myself, I'm already covered. But, in the last 5 years that we've been around, we've had the privilege of serving more than 85 million families, right? And I think that's the power of digital. Of course, it's not the same as sort of physical interactions that Dr. Pai referred to, but I think that is something that, we hold very dear. And in fact, just last year, we had more than 9 million families use Baby Chakra, right? We have more than 10,000 doctors and experts on board because we believe that the process of, digital care in the pregnancy and parenting space, while, so again, I think from a public health background, having seen the power of communities and community information and community sort of interaction in creating behavior change play out, the role of experts and doctors, right, HCPs, is critical in ensuring the right care is also practiced, right, and also disseminated and sort of engaged with amongst communities. And in fact, I think something that I'm very proud to say is that because of the platform we've built out, we've had more than 40% of our users actually told about Baby Chakra through either, peer parents or through, experts and doctors, right? So it just goes to show that we're creating something that is meaningful, that's adding impact. Apart from that, I think just a couple of other things, right? I mean, Healthline, which is one of the largest digital health publications in the world, we were the only app from Asia selected as the best pregnancy app globally by Healthline in 2020. Matter of great pride, because, you know, when I moved back to India from Boston, you know, Dr. Hema, I was told that, why are you building out a product company, a tech company from India? Why don't you just build it out from the US? And I was like, we're going to make it in India, right? You're going to make it happen, make it in India, right? And of course, some other sort of pieces, right? CB Insights. You know, we've been privileged to be part of the Niti Aayog in 2018 on the Committee on Maternal and Child Nutrition. So I think those are some of the pieces that we are proud of, and you know, I think it shows that we're creating impact, at least some way we're on our mission.
Yeah.
Rajni, you can move to the next slide, please. We can skip this. We've already talked a little bit about this. So I think, you know, we were coming back to, you know, why digital, right? Now, of course, goes without saying, I think the physical interaction that Dr. Pai referred to amongst communities is absolutely critical in behavior change, in impacting care protocols, in impacting nutrition protocols, right? It goes without saying. But at the same time, we're talking about, you know, more than 100 million mothers today, right, who are online, who have access to the phone, right? And it's very interesting because when you look at the rate of growth online, right, on Google,
Super.
WhatsApp, right, you see 150, like you're seeing 150% year-on-year growth.
Yes.
On parents online asking
Amazing.
questions around health, wellness, nutrition, right? So there have to be platforms that serve these needs, that serve the parents who are already online, right? And I think just the other piece to it is that when you're talking about women who are coming online for the first time in history, right? The first time they have access to the internet, they start with a place of inquiry. They start with a place of aspiration, right? They want the better care. And they start with a place of trust, right? So it's extremely critical, therefore, that what we bring forward to these constituencies and to these families is very, very high trust, credible, community-oriented content, right? So they feel comfortable asking their questions, so they feel comfortable engaging in these communities, right? Because especially pregnancy and childcare can be a journey of like a lot of like a lot of judgment, a lot of questions, a lot of ambiguity. So if you just move on to the next one. So this basically just tells you what, you know, this is an overview of the app. We are in 5 different languages: English, Hindi, Tamil, Kannada, and we're in Marathi soon. And if you just move to the next one again, this is a bit of an overview. So, you know, the platform is not just a content platform, right? It's actually personalized to each parent who uses us. So the minute you download the Android app, right, the whole journey is that we basically ask you, like, are you a mother? Right? Or are you a father? By the way, we're the only platform. Again, Dr. Pai, right? I think it's so interesting. And I think there's hence a resonance. He said that, and it's true, right? If you look at the internet split in India, right, it's a 70-30 split, 70% male and 30% female, right? So if I want to be a part of families and, you know, work with them in impacting with care behaviors, right, I need to be talking to the father as well. So we're actually the only platform, parenting and pregnancy platform in India that actually has a journey for fathers as well, right? So anyway, so we ask whether you're a mother or a father. We ask about your life stage. We ask about your interests, because we ask also about your language and of course about your locality, because a mother in Chandigarh versus a mother in Chennai, right? Her needs change, her needs evolve, right? And then we basically lead you through a very personalized digital journey, right? Right from like your birth club to your daily tips, the questions to, you know, emotional wellness questions, or pregnancy wellness questions of foods to eat if you're pregnant versus, let's say, if you have a child at home and you're thinking more about toddler nutrition or about, you know, complementary foods, etc., right? Weaning foods, etc. So it's a very, very personalized journey. Lactation, right? Big bunch of questions around breastfeeding and lactation, right?
Right.
So that's the entire journey. It's very personalized. And I think that's, we move on to the next piece, if you don't mind, Rajni. And I, you know, want to call out, I think that's the power of digital, right? And that's the power of sort of algorithms, right? So if you personalize based on each parent's journey, right, you're able to truly create a unique personalized care journey for each parent. Right. And that is, possible because we've actually created a unique recommendation engine specifically for pregnancy and parenting, right, in the digital space. So if we just move on to the next one. And hence, I think this is some of the impact metrics that we track, right? That we actually support behavior change. We actually support decision making for young families, right? So, we do, I mean, of course, we try to understand the impact we're creating. So every quarter, we're basically trying to understand from our families, did we make an impact, right? So, and what we find is that, yes, we are making an impact in terms of them ensuring that they take more informed choices on health and education, and of course nutrition being a very critical part of health. Child nutrition, weaning, lactation, breastfeeding, I think we've seen that being a very important part of the behavior changes, or sort of the impact that they take away, right? Also prenatal diet and nutrition, right? That is another very important component of some of the care protocols they decide to absorb into their daily lives, right? And of course, when we have a protocol of reminding you through a daily tip, right? I think that also certainly helps in changes in behaviors, right? And of course, I think the other piece which we talk about is how did you hear about us? And they hear about us through their peers, through their community members, right? Or through experts, which I think again shows that we are doing something good here. Again, to call out, Dr. Hema, there is so much misinformation on the internet.
Yes.
Right. And I think this is where, I mean, this is the fundamental belief we have in collaborations. And we are very fortunate to have found a very large community of about 10,000 practitioners, experts, as well as HCPs, right, who have basically said, we will partner with Baby Chakra because we know you have the reach and the relevance with the community, but let us partner with you so we disseminate the right information, right? It is not just hearsay. It is not just, and, like, in our heads at Baby Chakra, what we say is there's experiential information and advice, right, which is coming from peers and community members, but there's expert information and advice, right?
Absolutely.
And so, the points where it requires an intervention of expert in, information advice, we have the privilege of actually working with HCPs and mission aligned, experts at scale. Right. Just moving on. And therefore, you see the depth of engagement, right? So you have users, our families actually asking more than 100 questions a month. That's the bulk of where the questions and posts and, very, very deep engagement, right? So again, I think that's the power of digital, where you have the person has you on their phone, you're easily accessible, right? So you can deeply engage as well if you're giving the right, relevant, credible information in a personalized way. And that again is the power of digital. Just moving on. And I mean, this is some of the sort of the data that I'm just sharing with you in terms of the interest distribution, right? So, what do moms think about? What are moms talking about? What are moms interested in, right? So there's, conversations and questions around baby nutrition, delivery, family health, home remedies, mom health, mom nutrition, mom sickness, pregnancy milestones, pregnancy recipes, right? So there's a very, if you look at the back end, right? There's a very, very large database of what are mothers thinking about, right? Real time on our platform. And then we sort of use the recommendation engines to ensure that we're serving up the right, credible, personalized information, right, to them at the right time, in the right junctures. Just moving around, I want to talk about this also. If you look at the 80-20 split, 80% are moms who are registered users, but 20% are fathers, right? And as I mentioned in the beginning of this conversation, we are the only platform with a father's journey because, we've seen so many times, and it sort of accelerates more in, tier 3, tier 4 contexts, right? Where fathers have access to the phone or to digital, and then they use this information because they're also equally lost in many ways, right? They're fathers for the first time.
Yeah.
And they use our platform to make informed choices, and then they pass on these choices or these thoughts or these suggestions to their spouses, right? So that together as a unit, they can care better for the wife who's expecting or for the child at home. And, we have folks from more than, 300, 400 cities and towns in India, right, coming in. So this is just, I think, a very broad overview. I think, you're looking at a 40%, our demographics are basically 40% expecting mothers on our platform, 35% new parents. So, 0 to 2 is we call new parents, and then the balance are toddler parents, right? So 2+, right? 2 to 5. And in fact, mainly 60% of our user base and families come from tier 1 to 3 towns and cities. And we get millions of insights, live insights on what is top of mind for our mothers, right? So we can serve them better. We can move to the next one. And hence, I think you see the amount of content that mothers are consuming on the platform, right? I mean, on a monthly basis, you're seeing them consume more than 100 million or 60, like depending on which month you're looking at, right? Between 100 to about 60 million pieces of content on the platform. So the mother who's online today is literally hungry for information, hungry for content, right? And I think
Yes.
this is something that I just wanted to bring forward for your consideration. And I think the last slide now, probably, or we're probably done. Actually, we're done, right? So
Yeah.
that's a brief overview. I just wanted to spend like 5-7 minutes.
Okay, Maggie, with the name Chakra, it's 360 degrees. In fact, your entire presentation was so eloquent and so wonderful. There are 3 rapid fire questions to you, Sagi. One is that what is the increasing demand for more number of languages? You said 5 languages, but we know that there are so many different dialects in the country, and also especially what could be the reach to the tribals and in their own language. What is in the pipeline?
So, the aim here, Dr. Hema, is how do you at least launch in another 5 to 7 languages over the next quarter?
Yes.
And we've identified which ones, right? I think that is the aim. Unfortunately, Dr. Hema, I don't think we are at that level of the technology we have. I think we are good in a tier 1, 2, 3, and 4 setting. I think with maybe a more tribal audience and a tribal family construct, right? It definitely requires a very different kind of thought and a very different kind of a platform, right? We're still talking about a smartphone user here, right? And of course, like while the cost of smartphones, the cost of data, right? We're talking about a data democracy right now in India,
Sure,
right?
sure.
It's the cheapest in the world, right? So that has gone down, but it's still to percolate, I think, some constituencies. And I don't think today we are well equipped to serve the needs of tribal families and constituencies.
Yeah, fair enough. A long journey, but has to begin with the first step. And I think you have well traveled quite many, many miles, and congratulations to you. How much does nutrition, maternal nutrition, or all the 3 points that Surjit said, pre-pregnancy, pregnancy, post-delivery, what is the component of the nutrition by way of awareness building or the information dissemination?
It is an extremely critical part, Dr. Hema, and I just want to call it out. I think, you're looking at, of course, like anemia levels in India being what they are, right? And that, how do you, and that starts from like, when a young child, a girl child, is basically being raised, right? And then, of course, you go on to a pregnant mother, and therefore the incidence of anemia, how important that is in having a healthy pregnancy, healthy baby, right? And for her own health, right? And you see, of course, therefore, then how does she sort of translate her previous behaviors to how she takes care of her child and herself post-pregnancy, right? So nutrition for us is an extremely critical part of the platform. In fact, I would say about 40% of all conversations, right, in most life stages and more, accelerated in different thematics, right? So, post-pregnancy, immediately post-pregnancy, lactation, breastfeeding, right, is a very, very important topic. And in fact, 0 to 3, so when a mother gives birth, 0 to 3 months, right? And especially within that, the 0 to, I would say, 6 weeks, that period of time, right? How do you really support a mother to not give up, right? To find the right resources on lactation, on breastfeeding, because, mothers can give up as well if they don't find the right support and the communities of care, right? And I think digitally, that's the aim here, that don't give up on breastfeeding and find the right care you need. So breastfeeding becomes a very important part. And I think post 2, like, and of course, 6 months plus, right? Because that's when the child is transitioning from breast milk to other forms of weaning. And I think there are questions, right? Should we get like processed, like, foods from the market? Should we do khichdi's? What do we do, right? There are questions around that. And I mean, again, I think, thinking about what is the context in which the mother operates in, the family operates in, right? What is the local, regional, produce that the family has access to, right? What are the developmental milestones the child is at, right? And then sort of thinking about working with the mother in helping her make some choices. We don't tell her what to do. We may help her make those choices, right?
So one last question from Vani Sethi, which I want to voice it out in a little different way. We have oftentimes as OBGYNs and clinicians confessed that we are not the best people to give advice on nutrition because we know very little, and the way we come across in communicating the same to them is also a little flawed. So whilst you say on one hand that you have 10,000 doctors on board and so many are collaborating, the question from Vani is, who validates the information that you give out about nutrition, and is there any thought process of collaborating with organizations like NIN and other communities who are dealing with the diet and nutrition to make it, reachable in the way it should.
I mean, that's the reason I'm here, actually, Dr. Hema, because I truly believe in the power of collaborations. And the knowledge and the literature on nutrition is evolving so rapidly globally, right? And especially in India, right? We're learning so much about nutrition and best nutritional practices, right? Every single, the milestones are moving so fast.
Yes.
And I think for platforms like ours, right, the idea is that, again, it starts from a mission, right? How do we provide the best care and partner with our families to ensure the best care, right? So, I mean, I think absolutely welcoming collaborations. In fact, the idea here is how do we make the information we disseminate to our parents correct, right? Help them make more informed choices, and also stay on top of what is the scientifically correct set of types and choices.
But thank you so much, Naya, because your open-mindedness and honest submissions of what you've been doing and how far you have reached, which is immense, according to me, and also the future when we, on one hand grumble that there's so much misinformation in the WhatsApp university and there's so much going on in the social media, then we have to reflect and say, what are we doing about it? And as you rightly said at the start, doing your bit has been very, very crucial for this mission of Baby Chakra, and we are all here to pledge our support in any which way, because I really do think that if the misinformation has to recede to the background and people have to eat right and get to know the right information, it is very well taken that millions of users are already on the chakra, and we are here to move the needle even further. Thank you so very much, Naya.
Thank you, Dr. Hema. Just to reiterate, we are here to learn, we are here to collaborate, and I think the mission is very clear. We're all mission aligned, right? So we're very open to it. Thank you so much.
Thank you so much. Next, it's my pleasure to invite Dr. Aparna Hegde, who threw a surprise out of the blue a decade ago when she was discussing about the initiative of Arman and Mitra and how she would want to give the tips and advices and awareness messages to the community, reaching the nooks and corners of the state of Maharashtra to start with. And of course, now it is really, really grown big. And I'm aware of the huge collaborations that she's into. Now, let's hear from Aparna. It is quite an achievement, an accomplishment, and I'm so very proud of you. And out of the box, from urogynecology to doing your bit to the girls and women out there. So Aparna, all yours.
Thank you so much, ma'am. It's always a pleasure to have you in front of me. And I am practicing urogynecology, you know that, right? I'm also a professor in Kama Hospital, so I would dual life urogynecology and Arman. Yeah, and thank you so much. And you've been witness to the journey. So I would love to kind of present from the very beginning to what, and I have a very short presentation, 5-minute one. Sure. Yeah, thank you so much. Can you see? Yeah. So Arman currently, it was founded in 2008, and now currently we're in 19 states, and our work has reached out to 26 million women and children, and we've trained 200,000 health workers. We also currently manage two of the largest in collaboration with Government of India, that is Kulkarni and Mobile Academy. And Arman in 2020 received the School Award for Social Entrepreneurship, and I'm very grateful to have a team of 130 who share our journey and our goals. Now, what do we do, right? So Arman came from my experiences during residency, where I closely saw how, because of very crowded antenatal clinics inside a hospital, we didn't have any time to counsel women, right? And they would come back dying, or the children would come back malnourished and dying, because if you don't have any information about the danger signs, where you need care, what are the, complications that can happen during pregnancy and childbirth, it can lead to increased maternal child mortality and morbidity. And similarly, on the other hand, I realized that you have inadequately trained health workers in the field, right? Who are not supported to be able to pick up these risk factors early enough, so that women and children are treated in time before they reach tertiary hospitals in a delayed manner, right? And that's when Arman, the idea of Arman hit me, because I realized that India's scale of problems is so huge. To really impact at scale, you need to use technology. That's when the mobile phone came to India, and I saw suddenly how in a few years it spread through the country, right? And it was a tool that you could use to reach women yourself. I mean, you could reach women directly through pregnancy and infancy, weekly with information. And on the other hand, you can also use a mobile phone to train health workers, right, for timely detection of risk factors, right? So what we do is that we leverage technology to create scalable, cost-effective solutions, but we also leverage tech plus touch model. I completely agree, technology alone is not enough. So all our programs leverage existing health infrastructure and the health worker network of Government of India and partner NGOs. And we don't do just a technology program, but what technology allows us to do is to keep the number of human resources required, to bare minimum, so that we reach out to women more often through technology. They can still come back to a call center or the health worker on the ground or the hospital supervisor with any query she has. So she has this face-to-face contact also, and that leads to non-linear growth of program. And obviously all our programs are designed using community needs assessment approach, and we are always very evidence-based. So what do we do? Our first program is something called as mMitra, right? mMitra came from my experiences in Sion Hospital. I'm very happy to say that it started out there. mMitra is a free weekly voice call service. The voice calls have been developed by Arman and Baby Center and have been validated by experts from FOXI and National Neurology Forum and IAP, and pre-tested in the community. So we enroll women in mMitra wherever we can get them, right? So women come to antenatal clinics. So we have hospital supervisors stationed almost 100 hospitals who enroll women as soon as they come for their first visit. But women come to the hospitals too late. So also we have collaboration with NGO partners on the ground, right? And through that incentivized health workers, we financially incentivize them. We enroll women as soon as possible during pregnancy, right? And then what happens is that the messages are timed and targeted. So at the point of enrollment, we take that phone number. It can be their phone or the husband's phone or family phone, but we also take a time slot choice when they can, ensure that the phone is going to be with them. We take the gestational age or age of the child because the voice calls are timed and targeted, right? And we also have a language preference, right? mMitra is in 5 languages. And then we have around 141 voice calls, around 60 to 120 seconds duration, literally twice a week in pregnancy and twice a week in infancy. So in the chosen time slot it's sent, right? So for the first, suppose you have 2 messages per week. So we will send each voice call 3 times on 3 successive days in the time slot that the woman has chosen. If she misses all the 3 tries, then there's a missed call system. She can give a missed call to system. System will call her back with the information voice call that she's missed. We also have a call center, right? So she's delivered and if wants to switch to infancy messages, she's changed her phone number, she's changed the time slot, or she's aborted and wants to stop the messages. Then she can give the call center staff will call her back. And now we are getting all queries. So our trained counselors handle any queries coming in, right? We have a 30-member call center with mMitra. Now, mMitra went to 2.4 million women in 9 states. We have almost 8,000 health workers on the field over time, 100 partner in hospitals and 43 NGO partners on the ground. And the impact of mMitra we measure through RCTs. And I'm very happy to talk about, our impact on nutrition of mothers, right? So we look at iron supplementation. This is an RCT that we did with DFID UK funding in rural Maharashtra. And we had 3 groups, a control group, the mMitra group, and then we had a group which also got mMitra and home-based care. And we look at the proportion infant mothers who took IFA tablets during pregnancy for 90 or more days, last column. You can clearly see that the mMitra group did really, really well, 70% as opposed to 45% in the control group. And it did quite well when you compare it to the group that even got home-based care, right? This impact has been very, satisfying for us. And if you look at the impact on infancy feeding, right? So if you look at breastfeeding parameters, right? Proportion of infants under 6 months who are exclusively breastfed, women who gave colostrum to the baby, women who practice early initiation of breastfeeding, women who wean the baby at 6 to 7 months of age, or women who do not give prenatal feeds. All of them, mMitra did really, really well as compared to the control group, and actually did admirably well. And in fact, if you look at the p-value, it's comparable between the group that got mMitra and the group that also got home-based care. So that really was encouraging for us that just voice calls to the women supported by a call center can give them, the necessary tools to, develop the behavioral change required to exercise better behaviors, right? And we also did a pre-post intervention study, right, for Mitra, in which we clearly saw that if you look at women who got Mitra, 96% of women who got Mitra sought treatment for complications during pregnancy, right? And the proportion of women who suffered from pregnancy-related complication only 9% when they got Mitra, as opposed to 38% when they didn't get it, right? So, and if you look at immunization schedules during infancy and pregnancy, obviously proportion of women who got Mitra, practice it much more than the ones who did not, right? So these impact studies really led us to a point where the government of India came to us and said that, why don't you manage the Kulkarni program? Now, Kulkarni is a program of the government of India that runs in 17 states now, and we've been managing it from 2018. It's a voice calling service, again, like Mitra. It's got 72 messages. It's in 5 languages, and there are 9 attempts for each language, right? And it's in now the goal is for us to go from 24 million that we currently serve to literally 45 million in 5 years' time. We are in the 10 North Hindi speaking states and Northeast states, and also multiple union territories, around now 17 actually, right? Not 15 as the slide shows. And Kulkarni impact also has been recently published on. And if you look at an RCT in rural MP, it is found that exposure to Kulkarni content, was significantly associated with increasing men's knowledge, right? So this whole thing about voice calling services related to, linked to what is the men's information about, all these health information. And what we realize is that, when though we give a time slot to women to get the voice call themselves so that they can keep the phone with them, oftentimes the men hear the calls and they record it and the family listens to it together. And Mitra and Kulkarni both have been shown to increase the husband's knowledge regarding a lot of parameters, and this is on the child immunization bit, right? We also manage, so the whole idea is this, right? We send voice calls, so we hope that this will lead to increased information on the part of the mothers and the family, and that will lead to better health behaviors, and they'll go on demand care. But on the other hand, you also want to train health workers, right? So the Mobile Academy platform of Government of India we manage. So Mobile Academy, again, is a mHealth-based refresher training program for ASHA workers. It runs in 17 states. It's got 11 chapters, 4 sections to each chapter, 4 hours of content. And the ASHA worker can call in and call off anytime she wants to. And next time when she calls back in, it takes, she goes back to where she logged off earlier. So it's again, is going to spread through the country in the next 5 years. Another big important program I want to bring to your notice is in Telangana, and which will then hopefully going to go to Andhra Pradesh soon. One of the biggest problems that we saw in the field was that if you look at high-risk pregnancy, it's not enough to have ASHA workers and the health women aware, but you really need to have the cadre at various levels. You have the auxiliary nurse midwives, the medical officer, and the specialist in rural India, who need to be aware of their part of the role of identification, management, and referral of high-risk pregnancy, right? That's where the big gap is, because ANMs do not know what is their part of the role, when they're supposed to refer. Same thing with the medical officers and the specialists in district hospitals. So, we, as a part of the Antenatal Care Guidelines Committee of Government of India in 2019, I proposed this whole thing about creating algorithmic color-coded protocols for each cadre, because you might have overall guidelines for high-risk pregnancy management, but each cadre needs to know their part of the role. And for 35 conditions, my team had created protocols, algorithmic, tabular, and then Telangana government accepted it, right? So currently we're doing this huge program in Telangana where not only have 20, the protocols have been modified to suit Telangana, but 27 prioritized conditions. We're currently doing virtual training and face-to-face training for over 9,000 ANMs, 1,500 medical officers, and 330 specialists. Now, we will be doing, along with the virtual training, we're also creating a learning app, right? Because you can't train only once, right? So all of this content is getting converted into multimedia approach, live action videos, simulation videos, notifications, interactive quizzes, and they will also be handheld through a call center and WhatsApp support, right? So the medical officer who trains the ANM medical officer will actually be available on a call center and WhatsApp support to answer any query that the ANM may have when she goes in the field and implements the protocols. Then we also have a tracking app. All of these protocols are becoming a part of the tracking app. It's a decision support tool that will take the ANM medical officer specialist to all of these treatment protocols, right, on the field, right? So it will help them understand the symptom, signs, diagnostics, and what they're supposed to do and when to refer. And then the tracking app is going to lead to dashboard at every level. Imagine the Commissioner of Health in Telangana, in Hyderabad, to the A&M in the field. Each one of them will have a dashboard to understand where they're going wrong and what is happening, and so that we can go into special training. So imagine like a part of Telangana is doing very badly in pregnancy-induced hypertension. We can go back and train the ANMs and medical officers, right? So that's an ongoing 5-year program that we are doing. Now, and this is in collaboration with UNICEF, so I'm very grateful for their support. Now, the thing is that Telangana is a place where Mobile Academy and Kulkarni we go next. So the whole goal for us is to create an integrated platform. So imagine, everything, all the databases are linked up, right? So what will happen is that we will actually be having every pregnant woman and mother, every ASHA worker and the ANM medical officer on the database. So if a part of the country are doing badly in pregnancy hypertension, through Kulkarni, we can inform the mothers more about it. Through Mobile Academy, we can train the ASHAs more about it. And through ANM medical officer training that we do, refresher training, we can train the ANM's medical officers better. And we can do through dashboards, understand how things are improving, because we're going to track every pregnant woman. We also have a long-standing collaboration with Google, and we have got AI integrated. So at every level, we've got artificial intelligence that is going to get integrated. That is going to help us do analytics and help us target the women better and health workers better. Lastly, I'm going to come to this very interesting program. I'm so grateful to Dr. Vani Sethi, who's there in the audience, who approached us for this program called Swabhiman. Now, one of the things that has really bothered me is about the equity aspect, right? We talk about technology. How do you reach the last mile, right? Women don't have access to technology. Also, you have all the disenfranchised groups, right? Talking about migrants, tribals, you're talking about lower caste, right? Religion, different religious groups, right? So the problem with technology is all our programs get created through equality lens. Now, how do you get equity into the perspective, right? So, and UNICEF has a wonderful program called Swabhiman in some of the 9 of the worst, 22 districts of the worst, 20 worst districts of 9 states of India. And it's a program where they train the village self-help groups, right? So the village self-help groups come together. It's a lateral approach to the women, right? Because they are from the same community that the women come from. And they've added health aspects, nutrition aspects to the role of the village self-help group, right? And so they came to us to add the M-Health bit of it, right? So we have this whole program in collaboration with UNICEF, Rajni, and the National Rural Development Mission, where we would be, adding these components in 9 states. And 22 districts and 100 blocks of these 9 states, right? These are the worst blocks in terms of equity perspectives. So what are we going to do, right? Here, when we talk about Kulkarni, now Kulkarni reaches these women in a manner that is, not at the level that, women who are actually, privileged yet, right? Because of the fact that they may not have access to the ASHA workers, or they may not get enrolled in the program, right? So if we approach the women through the chief resource persons of the village self-help group, the enrollment into Kulkarni will be better, right? So the whole idea is that we engage the CRPs into getting women into Kulkarni model, so that more and more women have access to Kulkarni voice messaging services despite their equity, right? Issues. We also going to have Maitri Kishori calls for weekly messages for adolescent girls, right? So the whole idea is adolescent girls, mothers with children, children who are malnourished, right? All of them can get voice calls regarding health, nutrition, and maternal mental health issues, right? For that mental health issues, the collaboration is with NIMHANS. We also have a Doctor Se Baatcheet program, which is a virtual clinic where we would have qualified doctors on the call weekly with these women in the field. The village self-help group CRPs will get these women together at a particular spot where they can communicate then with the doctors on the phone, right? Who can answer any queries and give them right advice. There's going to be a whole lot of initiatives in this Swabhiman on mental health of adolescents and mothers, which is an extremely important aspect to look at, especially in today's COVID times, right? So it's integration of nutrition, health, and mental health, right? And lastly, we're also going to be doing capacity building of the chief resource persons of the village self-help groups. And that will be through virtual training. There will also be a mobile academy kind of self-taught audio module hosted on IVR platform for the CRPs, right? And a chatbot for mental health, right? So we're very excited about this program. Now, as we go forward, right, we are going to go into a system where we will have a pyramidal approach, right? The whole idea is that if you're a low-risk woman or a woman with access to feature phones, you're going to always get voice calls. But as we go on to women and children with high risk factors, we want to do more hand-holding. We want to do more two-way communication. And if you have access to smartphones, we'll be able to reach out to you through WhatsApp or through multimedia approaches. And we've already done an RCT where in mothers with children who've got moderate acute malnutrition, we handheld them for 4 months to train nutrition counselors. And the data has just come in now, it's very exciting for us that women who are poorly educated, their children had weight gain. And 8 weeks of hand-holding through trained nutrition counselors. And it was very exciting for us. And the data that's coming in that, women who are disenfranchised, if you give them access to these services, hand-holding, they actually act on that information. And weight gain for us is a proper health outcome in malnourished children, right? So the idea is that we will do more and more hand-holding if you have more risk factors or you have access to smartphones, right? So as we go forward. So Emitra is going to become now a sandbox for Kulkarni. Emitra is where the platform where we're going to test innovations, like what's etc. And then we're going to scale up through Kulkarni. The same thing is going to happen with Mobile Academy. We're going to go on to version 2, where we're going to get multimedia approaches, interactive quizzes, simulation videos, multimedia live action videos, so that the ASHA workers also can get trained through these approaches, in addition to voice call services. Right? Our whole plan in 2025 is 45 million women and their children, 1 million health workers, and pan-India. That's the whole idea. Thank you.
Great. Thank you, Aparna. If Rajni were to put a poll and say, who does Aparna Hegde remind us of? The answer would be Shankar Mahadevan with his breathless singing and breathless. Your agenda is just flawless and flowing all the way through. Huge congratulations on behalf of all our beloved viewers and the distinguished panel as well. As you said, once is not enough. And therefore, even the messages go many times, even the training goes more than once. So that is perhaps the key, the re-emphasis and the retraining. Just one question before I move on to the next panelist, Aparna. All well. That's how it comes across with your presentation, right? So just tell me at least one challenge which you would have surely faced at the start or in the midway through this program. Anything that we can learn a lesson from.
Challenge was initially the acceptance of a program, right? We started Emitra, the whole idea that these women would get voice calls from a entity they're not aware of. These are women who never spoke to anybody outside their family, right? They would have access to a feature phone. They would speak to their husbands or their mothers-in-law, and suddenly they're approached in a government hospital by an NGO saying that we'll send you voice calls informing you about the care to be taken, right? So there was a little bit of hesitancy that we saw initially. And then going forward, the thing that we realized is that the minute they start getting the voice calls, it really, gets them into the program completely, because of the fact that these are women who no one talks to, right? So the thing is, the voice call, you're able to give not only the big picture information, you're able to support them emotionally, right? They have this elder sister voice that calls them up and tells them about the small things that you've been in government hospitals, how it is very difficult to give them anything beyond take iron, take calcium, and we don't have any time to give them the small emotional things that they need, right? And so when they have an elder sister voice that calls in, talks to them about small things that bother them, and then they have a call center that they can approach and call, talk to anybody, right? A trained person who answers their queries. It's they feel supported, right? And when that happened, I must tell you, we have health workers on the field who enroll women into Emitra. The women who are beneficiaries then became the health workers who went to the field and enrolled more women, right? So
excellent.
Spread through the community, and that was extremely encouraging for us, right? The whole empowerment angle, as a typical doctor, when I send the voice calls, I thought, okay, I will train them, they will remember it and they will act on it, right? There will be behavior. But what is the most exciting thing for us is empowerment angle. Within the first year of starting Emitra, we would hear stories from the field of women going and buying their own phones because they voice calls. Women about sex during pregnancy, women calling about family planning, right? Compelling their family to adopt family planning. So all those stories, the empowerment stories, is the real encouraging thing for us. Yeah.
I think it's been an amazing experience. And as the chair for today's program, Osama, said, that you have to bring in the humane angle, and that's exactly what you alluded to. So congratulations once again, Aparna, and thank you so much for being on the panel today. Next, we move on to it's women power all the way. I must say, it has been Nagi and Aparna, and now it is Little Flower Augustine, who is a consultant, scientific, team of ICMR NIN and the electronic decision support tool for intervention delivery by ASHAs. How has this been explored, and what is the research experience from implementation of this intervention is what Little Flower Augustine is going to deliberate on. Go ahead.
Thank you so much, Dr. Hema. I'm extremely happy to walk you through the experiences that we had while designing this electronic decision support tool for intervention delivery by the accredited social health activist. Can we have the next slide, please? So this electronic support system was designed as part of an ICMR task force study, impact evaluation of screen and treat approach of anemia reduction, which is a cluster randomized trial in rural Telangana. We were trying to look at whether the screen and treat approach for anemia control will be more effective in increasing mean hemoglobin at population level and reducing anemia prevalence than the existing anemia control program. By screen, I would say that it means we are trying to screen the population using a point of care method, using capillary blood sample and autoanalyzer. And by treatment, we are trying to treat the population using iron and folic acid through the ASHA. And this is a community-based cluster randomized trial in rural Mestre district, currently running in 14 villages. And the unit of randomization are clusters of household covered by ASHA. We are covering a wide range of population groups, starting right from 6 months to 50 years, and the duration of follow-up is 6 months. Next slide, please. So while the screening part was running comfortably well with the method being established, we had quite a lot of challenges when we planned to roll out the treatment through ASHAs based on the Anemia Mukt Bharat guidelines, which is currently running in the country. I would say the challenges were with respect to the population, that there are 8 age and gender groups involved in the study, and 4 different age and gender specific cutoffs for anemia, and also different types of doses like prophylactic and treatment doses, while we have very less time to deliver the treatment within a span of 3 months. And in front of us, we had moderately educated ASHAs who are educated up to 10th grade. Next slide. So for to integrate all the activities of the project, we had a custom software designed in partnership with Kevin Corporation Bangalore. As you can see on the slide, we had 2 Android applications for the field team to collect data and also to do the follow-up. And as I already mentioned, that we are using a point of care method using capillary blood and autoanalyzer. So the custom software is also capable of pulling this data directly from the autoanalyzer, sending it to the server, processing it using a decision tree, from where this is sent to the an Android-based application for the ASHA, and she directly gets the decision on whether the participant is anemic and how much dose of IFA should be given to the participant. Next slide. So these are the components which are integrated into the algorithm-based decision support system in the Android-based application, that is the different cutoffs of anemia and the prophylactic dose or the treatment dose and the exact and the frequency of the dose as well. Because this is an Android-based application and the decision tree has been incorporated into it, we were able to directly calculate the exact amount of dose which is needed in the case of children. Generally, in the Anemia Mukt Bharat guidelines, it will be like a slab, like 1.5 or 2 ml per day. But in our system, we are able to directly calculate how much exactly the child requires with a dose of 3 milligram per kg per day. Next slide, please. So this is the display of the decision support system. You can see that in addition to the direct identifiers, the ASHA is able to see in a very interactive format that the status of anemia, that is whether the participant is anemic or not, and also the color and the pack that has to be dispensed. Also the quantity per day, the dosage per day, and when it has to be taken. And this permutation and combination has been done for different age groups and different gender groups. Next slide, please. So in the case of prophylactic dose, as you can see in the panel at the middle, there's a calendar also inbuilt into it showing the fixed day dose and the weekly dose that the participant has to take. And in the case of severe anemia, the ASHA will get a prompt that the participant is severely anemic and needs to be referred to the nearby PHC. Next slide. The custom software also has a web report where we get the reports on the spot, and this way we are able to monitor them properly and give enough guidance also if there is a problem at the field level. Next slide. So at the field level, we also try to get a feedback from the frontline health workers, about 42 of them, asking them like how did they, showing them the this electronic decision support system, giving them time to go through that and try it out, and then we ask them how did they feel about it, and we got a very extremely good response from them saying that it will save the ASHA's time in administering the IFA tablets, and they don't have to memorize all the doses, and it'll be very useful for generating accurate decisions about IFA tablet distribution, and the ASHA will feel more confident in dispensing IFA supplements to beneficiaries. Next slide, please. So to summarize with, the design EDSs appear to be simple and useful for the FLWs, but further studies on acceptability and utility need to be undertaken to understand the scalability of this application. Thank you.
Thank you so much, Augustine. In your research initiatives, how much do you see the gap in the research findings that you have? You disseminate the information, the evidence is there, but to make it actually touch every point right across this massive country, how do you see that gap being filled? How much more you need to do to work towards that? So,
yeah, absolutely right. I think theory and practice generally are not like theoretically we can have a good model, but how it works in the field is sometimes a problem. But we are getting a very good feedback regarding this particular decision support system from the ASHAs for the simple reason that it is in their local language, and also it is very simple to use. So what we did to manage this gap is at the beginning itself, before designing the prototype itself, we kept the ASHAs in the loop. So we used to go and ask them like, how do you feel about it? Do you feel that it is simple to use? And that way it has undergone a lot of permutations and combinations to come to this stage. And I truly agree that it has to go much way further to reach its goal.
Yeah, because I think you hit the right point, because the issue of the language and the simplicity and to whom it is meant for use, the frontline healthcare workers, the ASHAs, even the semi-skilled who can be empowered with a little more skilling on the point of care devices. I think this is a brilliant start, and it will go a long way, because this thought process has to be enhanced and amplified more and more. So thank you very, very much for sharing your experience. Yet again, another important issue to be discussed by Dr. Archana Sarkar. GIZ. It's all tongue twister in the German language, and I would refrain from expanding it, which says Zuberman Belt and some international organization. That's all I can say, Archana. But M&E, monitoring and evaluation, which is the key part, because it's so easy to begin something, but what is the impact that it is making is through and through with the M&E strong profile that you have. So the experiences shared through Dr. Archana Sarkar. Welcome to the panel.
Thank you, Dr. Hema. Thanks a lot. Welcome all. And I would like to present another last mile technology that we developed in cooperation with the Department of Women and Child Development in Madhya Pradesh. And this is known as Anganwadi Shiksha, or e-learning training platform for the frontline workers in Madhya Pradesh. And GIZ is, as you know, this is a German development corporation, and it's in cooperation with Indian government and the German government. And this initiative, Food and Nutrition Security Enhanced Resilience, is an initiative of One World No Hunger, and it's a global program run in 10 countries currently, and we aim to improve the nutrition and food security for women and children through different interventions. And one of them is through e-learning. Next slide. Yeah, thanks. Maybe you can just click the next one also. Rajni. Yeah. As we all know, the Anganwadi workers, they are the frontline workers for nutrition for women and children in the rural areas mainly. And we have, as you all know, that they have knowledge gaps, and also the variation is in education level. A lot of them have basic educations like 10th pass or sometimes 8th pass, but their native intelligence is very high. And in the remote locations, in remote villages, they have lack of access to further training, and sometimes there is cognitive overload also for a basic education person. Like there's 160 pages of content on each module. So we developed to fill in the gap. The GIZ Funds project, and now it is called as SENU project, which is securing nutrition enhancing resilience. And together with the Department of Madhya Pradesh, we developed this Anganwadi Shiksha to help systematically build Anganwadi worker capacity through a digital world and through videos, quizzes, and through a various very interactive training platform. Next slide. Next slide, please. Yeah, so the features of the training platform, it is that it's a profound learning with 40 hours of e-learning. And then what we did in particular was the gamification of the e-learning. Like we played a lot of games and pictures and quizzes and cartoons and sketches, and a lot of sketches and animation sequences were done. So that the Anganwadi workers find it interesting, and we've almost made it like a real life scenario. The next clip, please. Yeah, and also we had also we had some assessment questions for Anganwadi workers so that they can test their knowledge. It's a very in an easy quiz manner. It's not a very difficult way, and the language is of course Hindi. And for each module, they got a certificate, and at the end of when they completed the whole training platform, which is quite a lot of 40 hours, which means they took at least 15 days to complete the training platform, and they got a successful a certificate from DWCD as a part of as a recognition for their effort to being digital. And the next slide, please. So we also had with the government, we also had an MIS where we actually incorporated this Anganwadi Shiksha dashboard, and here the MIS or this department can monitor that how many Anganwadi workers have started the module, how many have logged on, how many could complete how many modules, how many have successfully completed the whole training platform, from which district, from which villages. Everything could be monitored from the dashboard, and it is still working with the DWCD in Bhopal. And the CNK Technologies, which is based in Hyderabad, they helped us in developing this. It's like an app, but it is also can be accessed in a web-based learning platform, in a tablet, in a desktop, whatever. And it is both online and offline. One can download the modules and also run it offline also. So it is covered. It is equipped for a remote centered learning also, remote area learning also. The next slide, please. And then we did a study to understand how this platform is working. What are the changes, or what are the implementation challenges this platform is facing in the village, and how can we scale this up? And basically we started in the 2 districts, and slowly it was done in all the 52 districts in Madhya Pradesh. And so we tried to understand what are the challenges. So also we tried to understand if there is any modification to be on the content, design, and user friendliness, which were the key key variables for a successful e-learning platform. So a very brief overview of the study, because I also see the time is running. So the next slide, please. And we found that among the Anganwadi workers who were users of this training platform, and among the non-users, we found that knowledge enhancement was better in some of the areas of maternal and child health, especially in the areas of like IYCF or the growth monitoring and the home visits. Also, we also told them how to do actually community mobilization, how to approach the home visits, and also how does they encourage the community participation, which is so key, as has been emphasized by so many speakers today. And the next slide, please. So we also paid a lot of attention to the content, language, and visuals, because we believe that that is the key. And we found, and as you can see, some of the sketches they were all in video form, and they were all comprehensive. The feedback was they were systematic and also local scenario based. So we actually captured the local village scenarios, and the sketches were made on this. They were all animated. This whole video is animated video. And there are small capsules, and all the modules were made into quizzes, and a very interactive thing. And then at the end of the and each module was there was a small assessment, as I told you, then, and that reinforced the learning and the performance. And most of them said that the language was comprehensible, they could understand the knowledge and skills than in other training programs. And also I mean, they found it a little interesting, and because it was a profound learning and in great detail, like anemia and everything has been explained, so they found it quite interesting to understand. The next slide, please. The user friendliness was quite okay, but some of the Anganwadi workers who were not literate, they found it difficult to maneuver a smartphone. And the feedback mechanism, because we also had a feedback mechanism within this system, and the live dashboard, this was little difficult for the Anganwadi workers and supervisors to get familiarized with it, how to, how can they can send their feedback. But based on the study, we also tried to improve it with in support with DWCD. And yeah, as you say, that it took less effort and to learn using this e-learning platform for the Anganwadi workers. And the next slide, please. And we found that there were e-learning platform, or this e-learning course could have a great capacity to fill the capacity building gap and enhance knowledge, and it is also already being used as a refresher course in Madhya Pradesh, and also a lot of Anganwadi workers have already completed it. There's a lot of encouragement with the government also to do this. But however, we found that we need to systematically address the implementation gaps, because there was a kind of a training at the district level. Training was organized, and then it went to the Anganwadi workers from supervisors. So when to complete, how to complete. So there was some communication gaps at the last mile, which we still need to address. And this is very important for the scale up, because it is little new for the Anganwadi workers, and it's not. I mean, it's quite a intensive learning mechanism. So the communication has to be quite good. And there were also some recommendations to include content on counseling of men and other members, and admission to nutrition rehabilitation centers, NRCs. So in this current phase, we will include these modules also within the e-learning platform, and it provides like an opportunity to train frontline workers with like minimum resource mobilization, because they're all part of government workers, and most of them have a mobile phone at least, and they can easily use that. And they are using it in Madhya Pradesh. They are using it, and now we will probably take it to Maharashtra also, because our next this project has Maharashtra as one of the district. And then I think the last slide now. The next slide. Yeah, then we are also working in the upscaling and replication, and it can be easily adjusted in other states in India, and courses retaining basic content, the cultural and the other contents needs to be adjusted for other states. And it can be used in any other learning management system, and it can be incorporated in any other apps. Also, it can be used as a complementary learning with other available approaches like incremental learning approaches, which is more nugget based and incremental learning based. And we already have reached to 97,000 Anganwadi workers in Madhya Pradesh, and then it has a potential to upscale in other parts of India also. The last, I think that's all. The next slide, please. Yeah. Thanks.
Thank you so much, Archana. This is again yet another huge amount of work that has been put in by your organization, GIZ, the German Collaboration. Because of the expert in monitoring and evaluation, just one question before I go on to the three gentlemen who have been patiently waiting for the test to come. Thank you for your patience, sirs. Archana, monitoring and evaluation, that is the key. How do you monitor the quality of what they have imbibed through this learning? And just like a Chinese whisper, the message goes from one person to another person, and finally how it gets diluted, how it gets misinterpreted or miscommunicated is also a huge challenge, I guess.
Yeah.
So how are you addressing that?
Yeah, actually, we have now we are trying to work on the findings of the study, and we presented the study in various platforms. And based on that, we had several meetings with the government, and also because we are also in a new phase, we are upscaling this, and now we are trying to have a full-based monitoring system where we kind of see all these challenges, because the communication was a big challenge, the internet things were a big challenge. So we are trying to address it in an upscaling model. So we are still working on the upscaling model. How do we implement it more systematically? So we have not actually done a little short gaps or short plugging of the problems, but we have gone into a systematic upscaling strategy. So we have developed an upscaling strategy for this e-learning platform, and also the NPL, which is the nutrition education module. And we're developing an upscaling strategy which would include all the monitoring mechanisms to see that the communication gaps are addressed, to see that internet issues are, we have the internet issues in beforehand, so that the workers don't face any problem. And also how this moves within, because there are a lot of people involved in the government system, like supervisors, the CDPOs, the TPOs, how it moves within this system. So we are trying to channelize that through a training and monitoring system.
Thank you, Archana. A lot has been done, a lot more to do, and wish you all the very best. And yet again, this forum promises the connect and collaborate philosophy. And there's a question from Purnima Roy, who says, from where could we get all these resource materials? Is it an open source, or do you have to?
Yeah, it's an open source. Yeah, it's an open source. I can share the paper already with because it's already published, and also you can also access the app also. It just needs a login and password. So I mean, it's an open source, anybody can access it. It's not
excellent. Thank you so much, Archana. So now we move to the last three panelists in quick succession. Mr. Pais, I was wondering what C4D is. In case you guys don't know, it's communication for development. Okay, it's the health communication, the perception of the providers and healthcare workers, the technicalities, the jargons, the way we communicate. We don't even know how much it comes across and reaches. So the strength in the true methodology of the healthcare communication and everything around it to reach through the digital innovative platforms. Mr. Pais, over to you.
Thanks, Dr. Hema and NIN and all the colleagues. I think it's a exciting opportunity for us to participate. I can see 70 odd people still are with us, and it's a very good attendance. I would say congratulations for that. We heard so many experiences which is RCT and well documented successes. Here we are presenting something which is relatively new, and with me will be joining Anurag for some sections here. I begin with a small clip and then I will get into the PPT.
Welcome, Anurag.
हेलो दीदी, नमस्ते। फोन द्वारा हम लोग जो बात करते तो एक एक महिला से हम लोग बात कर पाते थे। और दीदी जैसे आप गर्भवती हैं तो विटामिन सी से जो चीज़ें आती हैं, खट्टी चीज़ें, ध्यान देना है कि हमें खाना है रोज। हाँ, आप खाना खाएंगे, आप तंदुरुस्त रहेंगे तो आपका बच्चा भी तंदुरुस्त रहेगा।
Keeping in view the short time for presentation, we kept this very short clip. Otherwise, we have other longer videos also. So here in this experience, we will be talking about one experience which started with self-help groups in Uttar Pradesh. And let me just put up the slides. So this experience started with SHGs in 6 districts, and as you can imagine, these are the districts. 3 of them were aspirational districts, and one of the most impoverished and poor in terms of development indicators, especially in nutrition and health. So we last year, actually, this whole experience begins from March, April last year. Before that, we were engaging with communities, with SHG women, and through them the families on basket of behaviors in health and nutrition. And the model was completely community engagement. So it was, using the theory of diffusion. We had SHG meetings in which very structured curriculum or the content was transacted. The moment COVID hit, it was very difficult to connect with families through these meetings. And so that was actually the start point. And we desperately looked for some way to continue the business. And first of all, we started, and that's what Hello Didi 1.0 is. We started with a small initiative in which we made our SHG leaders. They used to be called Wada Sakhi. So we trained them as telecallers or micro callers, and they became kind of mentors for all the SHG women and their families. And there was a very structured way to connect to families through phone calls, and for that they were trained very rigorously. So that was Hello Didi 1.0. While we did that last year, organically, we felt that this experience can be embedded with other projects where similar kind of situation is. And the larger department, for example, ICDS is struggling to promote nutrition behaviors, especially in families with SAM children, severely acute malnourished children. And with that, we began this experience of Hello Didi 2.0. And as organically growing, we became more intense, more structured. And here we are working in 3 districts in which the model is to reach out the families of SAM children from a set of counselors who are well trained, and the content is very much research based and well tested with these families. So it's a counseling in a way, but it's a tele-counseling, and then it's coupled with all the physical interactions that Anganwadi workers are doing in the communities. They have been trained on that. So we are trying to create orchestra of offline and online methods in Hello Didi 2.0. So a little bit on Hello Didi 1.0, and that was the beginning. So that gave us a lot of experience also as to how you can reach out to families through your federated women or women leaders. And the struggle started with phone numbers. And we all know that COVID, the way it is struck, there was hardly any time to prepare with a structured response. So the first struggle was to get all the numbers of families who were part of the SHG groups, and that was an experience in itself. And we are talking about areas with very low internet access, utilization, and penetration, ownership of mobile phone, etc., is also a big problem. Then the second was to switch over to the counseling content, because as many speakers talked about the emotional connect or human touch, and in these communities, we all know how important it is, that some trusted, some credible, communicator is talking to families, and there are multiple barriers that we faced. Then the third component was about capacity building, and we are talking about these women who never used phone for such purposes. So it was all, the first time experiment with this kind of initiative, and we learned a lot. Then while we were doing these calls, we thought of some system through which we can gather feedback, and we can see the quality of phone calls being made. And for that, we used, the online system to collect, feedback on quality. And then we did a quick assessment also, because we always knew that this is something new happening in our programming experience, and we have to use this data and experience to scale up or to use in other contexts, in other programs. So we did a quick assessment. There were some very positive findings coming from assessment, and that gave us a lot of confidence. And here we are seeing some data I just picked up from the multiple data set. One was about mask use, and we saw that the awareness and eagerness to use mask by pregnant women, and this set is coming from the pregnant women cohort, was very, very high, and they attributed to the repeated calls they were receiving from the change agent, Wada Saki. On nutrition dimensions also, we tried to see as to how they're learning new things, and the response was quite positive, because in terms of the variety of nutritious food or the food groups, we got a very positive response. And especially, we matched with the content that we were using in telecalling, and we got quite good confirmation that the messages were understood, and they acted upon that. So this Hello Didi 1.0, which began last year and ended in December, this gave us a lot of confidence and insights as to how we can scale this up or use this model in our nutrition promotion activities. So from here, this is 2.0, in which we presently are working on. This is something which is happening in the communities. I would invite Anurag to talk about it a bit.
Yeah, thank you, Bhai. Hi, everybody. So taking it from Bhai, the Hello Didi 2.0, what we tried to do was to address a specific problem in these three districts, which was basically how to accelerate the rehabilitation of SAM children, that severe acute malnourished children. So we designed this Hello Didi 2, and then subsequently we added another segment. I think last to last month, we also added pregnant women element also. We try to reach to the telecounseling center to this pregnant women also. So what is different was basically shifting from the micro caller to the centralized tele operations. We were tackling a much larger problem, which was like a complex behavior. Like, for example, some problems were like one-time behaviors we were tackling, like promotion of ANC. Some behaviors were like habitual behaviors like promoting diet diversity. Some also, the the problem was also about, how to move from the standardized to personal messages. For example, in the SAM families, children were at a different stage of different continuum of care was there. For example, there was the issue of provision of high calorie diet, but they were lacking the resources to do that, lacking the skills to do that. So that was the framework which we designed Hello Didi 2. Also, some of the problem statement also were self-help behaviors were there, and some behaviors were like system dependent. So how to accelerate SAM rehabilitation, how to improve coverage of maternal health services, how to address anemia among pregnant women, which was a new addition to Hello Didi 2.2. So some behaviors which were self-dependent could be done at a family level, and some were system dependent, that the family or the mother had to go to a service care provider to seek those services and utilize the services. So based on those parameters, we identified trained counselors and trained them and started this calling system. Next slide. So some of the unique features, in this our current statement, in the current program, is that these telecounselors are able to provide personalized support to the callers. And personalized support means, like, these are need-based appropriate counseling to the mothers, as well as many of the counselors are also reaching to the fathers also. All this thing is happening in collaboration with the NHM, that is National Health Mission, in these 3 districts, as well as the ICDS department, because they already have an ongoing running program there. So our task is basically to provide a consistent, constant reinforcement of these practices, as well as the services, to increase the uptake of these services, and through which what we are doing is by providing them some triggers to do that. Triggers where the telecallers would actually do is, for example, in a village, if they know in their database that they have 2 pregnant women, so they ensure that both the pregnant women actually go together to the ANC. So the other pregnant woman acts as a reminder or as a buddy to take the other person to the VHND center. Likewise, for example, just as a reminder to include oil in their, adding oil in the food. So because many times what is happening is the mother actually forget to add oil. So reminding them to, to keep that oil bottle, on the top of the utensil, child's utensil, So providing those triggers which act as a reminder for the mother to actually, uptake those practices. Another thing what we, the telecounselors, are also doing is they're employing techniques to engage, motivate, and enable these mothers to practice this behavior. We have developed a real-time diet assessment tool. What happens is that when the caller, in every call, what they do is they take a last 24 hours diet survey to understand the diet diversity, as well as the frequency and the amount of the food taken by a pregnant woman, as well as given to the SAM children. And very quickly, they are able to identify the problem gap and then, do an appropriate based counseling. Sometimes it's a problem of wrong choice of food. Also, issue of frequency of the food is there. So the callers actually customize the messages and then, provide that to the mother. Because of this, all this is happening, it is leading to an intensive dialogue with the caregivers. Our data says that around the average call duration between the caller and the parents are about 16 minutes. And also another thing what we have is our district presence of our staff. So a lot of calls are also going to our district staff, as well as to the ASHA workers who are also on the dialing list. And if there are some service gap, the feedback are provided to them so that those services uptake would be quickly increased. Next slide, please. So this is just a glimpse of our achievement, what has happened in last 4 months between call 1 and call 4 of the SAM children. And if you see the uptake of milk and milk products, vitamin A rich food, and the egg has increased among the SAM children, as well as SAM children consuming food groups has increased from 15.8 to 20.7%, like children consuming more than 4 food groups, recommended 4 groups. Also, before in the call 1, you would see that there was a long gap between the meals, which was about 4 hours and more. 53% of the mothers were actually providing a longer gap between the meals, which we had tried to reduce, and it's now only 12%. Yeah.
Thanks, Anurag. So I will conclude this. This is the last slide. So bear with me. So in this short period, we learned a lot, and we are trying to apply these learnings, in our other larger programs also. So there are three major learning that we have. One is the digital capability in social sector. We realize, especially during this COVID period, that it is one area which needs to move faster. It didn't get enough attention, and it needs to be supported. And center of excellence, or similar kind of approach can be tried out, especially in a state like UP, which is quite big. The other one is in NHM, ICDS. I mean, the flagship programs are there, and a lot of financial provisions are also there. So one major learning is to institutionalize this kind of experience, so that their delivery, communication, and training utilizes it. And the third one is public-private partnerships, because many innovations are happening in private sector, and we need to quickly learn and apply that in social sector. Some of the micro learning that we have. One is, as many speakers, and Osama began with that, the importance of physical engagement, community engagement, human touch, etc. So this is exactly our learning, that the conventional approach, and by conventional, we mean the frontline functionary or community platforms and digital platforms, they should be married together. And a correct mix, a right mix should be there. Then, as Anurag also pointed out, that in these digital outreach, we identify our specific audience, we create frequency, and we follow time sensitivity in our messaging, and that's a very big plus in this outreach channel. Then we also learned that women SHGs, it was not very difficult to reach out to women associated with SHGs, and there we learned that access to mobile phone in these families, access to women was much higher than other communities from where we had different experience. So, working closely with the SHG movement in the country provides us a lot of solutions. Then the other established networks, for example, the frontline functionaries, etc., we need a systematic capability development. And by capability development, we don't mean only a training, rather looking at different kind of investments that are being made in different flagships, so that they invest more, they train more, they supervise more, and the whole circle is completed. Then mentoring system for on-job support in these digital methods are very, very important. The other thing that we are always trying to nudge men, because in our decades of experience, we know that this is a kind of information dark area, information dark segment of population. They are hardly reached with health nutrition service messages or behavior messages. So they are also very important in our experience. There are challenges, but here you can see we put up one picture here, and we are always trying that they contribute in good family health and nutrition behaviors. And these are baby steps, because right now we are seeing that they have started waiting for the call. When they receive call, they like to talk to us, they like to gain more information, then they engage women. In certain districts, for example, Sonbhadra, which is a tribal district, we have repeated information that men receive call and they like to talk. So, and we are trying to understand that better as to Why it is so? Because they want to learn food and feeding practices, and they want to take charge. And then finally, cost effectiveness. It's very cost effective because we can see less engagement of army of functionaries delivering this kind of communication, and that's a good selling point for this particular method. On the right side, we can see we were just looking at one McKinsey 2019 paper, and according to that, and this is a favorite area for Osama, he keeps quoting all this. So India is one of the leaders in digital platform user or anchor, and I think this is the right time when we should look at social sector more closely, and we should prepare social sector for this digital future, which is right there. So this is the last slide. I stop here. Thank you.
Thank you so much, Bhai, for bringing in the Didi and with the Sakis and Mitras and Chakras. I think we've really had a very exciting session. Thank you, Anuragji and Bhai. And the last picture that you put with the father holding the child has caught the attention of Dinesh Baswaji, who says it's so important to involve the fathers for betterment of nutrition of children. So we really, really appreciate your presentation. We move to the last of the panelists, who is none other than Shantanu. Shantanu Pathak is the CEO and co-founder of Care Mother, and we would like to hear from him more about the kind of work that they do. Shantanu.
Thank you, ma'am. I'm sharing my screen as well. Thank you, everyone, for holding up and patience, and a great energy from Dr. Hema Divakar for holding up us, for this long session. Thank you for the opportunity, Sight and Life, ICMR and for allowing us to present this. So I'm Shantanu Pathak. I'm co-founder and CEO of Care Mother. We are primarily working in digital health solutions for pregnancy care. As a company, we envision creating equal opportunities of quality care for women. Primarily, our solutions are targeted for the healthcare providers. And since last 5-6 years, we have worked mainly in pregnancy aspect, focusing on lack of infrastructure in small clinics and government facilities, and also need of digital tools for at and beyond the care facility engagement. Through this journey, we have so far reached more than 100,000 expecting mothers from around 20 plus states of India, where we have partnered with 300 plus organizations, of course, individual doctors and government, as well as NGOs who are using our solution in cities as well as in the last mile care. In general, what we realized, the problem statement that we started addressing is access to pregnancy care. And while addressing this problem statement, few sub-segments, I would mention that we started focusing on quality antenatal and postnatal care with essential parameter checkup, high-risk pregnancy identification and management, fetal health monitoring. Importantly, we missed on talking on pandemic, but yeah, thank you. Home monitoring during COVID-19 pandemic. So COVID also brought set of complications during pregnancy for women, and there was a lot of chaos around it, and we tried to do some activities around it as well. So importantly, being a digital health organization, naturally our thought line was to empower the frontline worker with digital tools so that they can monitor, manage ANC, PNC and high risk conditions. How we can educate women directly, and also ultimately being an engineering organization, also build those tools by ourselves which can enable point of care screening and remote monitoring as well. However, although all said and done, we were about to start, and then we started learning and unlearning both. We realized that despite of building solutions, are the ANMs at the subcenter level in the governmental system ready to accommodate these solutions? This was an eye opener for us, that amount of workload ultimately put on them, and how we further convince them to use our solution. Although it is helping them, but ultimately when you are talking about the gamut of services they are managing, is it really fair to expect them managing additional tools? So this was one thought line, and second thought line was that most of the time the tools which are given to these frontline workers are seeking reporting. Now that's where the approach gap that we realize, that are we planning a reporting tool, or are we planning an intervention tool where the decentralized utilization of data happens, and every visit that A&M is making to mother, or every interaction they are having, is our digital solution helping them to make that visit meaningful in terms of giving some inputs, engagement, education, all those aspects. One gap which was also mentioned by a previous speaker, that like the medical officers who are ultimately managing the primary health centers and helping the frontline workers like ANMs and ASHAs, are they included in this ecosystem? So there was definite gap that we identified, that currently medical officers are not involved with digital health tools, and if we can focus on management of high risk pregnancy by inclusion of medical officers. So these aspects were considered, and care mother Anandima was introduced to focus on essential screenings for quality antenatal checkup, decision support tool for high risk management. We also recently introduced Mothers app in India, like outside India as well, and a service delivery engagement where we are collaborating with strategic partners who are working with government or by themselves as a healthcare providers to engage the doorstep delivery of these services. So what all we do, we have a portable kit of screening devices, which is a solar powered kit if required. So it's customizable. And we offer a portable kit along with the mobile app for frontline workers and medical officers. We also focused on particularly fetal health condition with a wireless cardiotocography solution for clinic, as well as baby beat for home monitoring. And the solution enabled, remote monitoring aspects in public health, or even in private health. Doctors are using remote monitoring solutions, and mothers are also using the solution at home for performing non-stress tests from home. Naturally, these all devices or ecosystem or the frontline workers required some decision support tools. So we engaged them with decision support tools, apps, when and where required. So how do we work? We offer the solutions to healthcare providers, pharmas, governments, and also to expecting mothers. We have gone to an extent where we have integrated the devices or softwares with the existing platforms, so that they do not create multiple softwares for the same thing. So to avoid that, we have made our system API friendly, where easy integration with other systems happens. The solution fits very well into the existing healthcare delivery of government, wherein, as I had already mentioned, we include all stakeholders, and ultimately they are able to see some value. So I'm going to quickly run a small video where one of our partners is providing services in Nandurbar district of Maharashtra. this was a small gesture, from the partner organization who offered services. The services are offered in various parts of the country now. We have strategic partners in India, mainly not operating in northern and northeastern as well as eastern part of the country. We also have now partners in Africa, Afghanistan, and Bangladesh. Recently we saw the challenges in Afghanistan. Fortunately, that just started working on the ground as well. So what happens once they use the solution for the decision makers? We do provide a lot of other activities in terms of real-time report generation for decision makers like district program managers or even for bureaucrats to identify which are the critical zones, also give some of them analytics understanding on particular conditions like outcome on pregnancy or birth weight. So those kind of things are observed. One, I won't say this is a RCT or study, but based upon the data that we had and data we collected from the district health offices in the areas where we are operating. So particularly we focused on two components, number of premature births and number of low birth weights. And we compared that registration happening in the first trimester or versus in second or third trimester, more than 2 antenatal checkup versus less than 1 antenatal checkup. So the difference was very consistent. Like you can see that registrations happening in first trimester. When we say registrations, we of course are covering the antenatal checkup. So early registrations are helping in reduction of premature births and low birth weights, and more number of antenatal checkups, at least additional 2 checkups, I would say, beyond the facility level checkup. These dual step checkups further added a value. Is the combination of only technology? Of course not. There are a lot of other factors, but we saw that common pattern all across the geographies where we are operating, that if registrations and antenatal checkups are regularly happening, the technology component here is basically enabling doorstep screening and identification of high-risk pregnancy and the referral that we could achieve. So that was one storyline. The second storyline we built around was digital fetal monitoring. So we all know that intrapartum death is one of the challenge, and fetal health monitoring is a regular practice. The way it is done in a different format at different places. We use handheld Dopplers to understand fetal heart rate. Doctors use stethoscopes to understand whether fetal is alive or dead. In better facilities, they also perform non-stress tests. So the challenge is how we enable NST at every places, and also make this NST as a better tool. So we came up with a wireless AI-powered digital fetal monitoring solution, which is available with more than 1,000 obstetricians in India today, and more than 10 government medical colleges, as well as some installations in Assam. In some of the PSCs also, it is being utilized. So the solution basically allows you to remotely monitor this test happening. So ANM or nurse can place the probes and start the test at one place, and you are monitoring this report in a real-time manner at other place. Importantly, it's very user-friendly. You can carry it anywhere. Portability gives that advantage. And we also saw that because of the digital record, a lot of other issues of either having thermal paper or keeping records, all those are eliminated, and it become very convenient solution for doctors and nurses to use. So as on date, more than as I said, 1,000 doctors are using it, almost 6 to 7 minutes per day to reviewing the NST results. What we did in addition, that once you see the graph, typically you would spend 3-4 minutes based upon experience of the doctor. The time required to assess the graph is different, but we also try to create the auto interpretation of the results, which further helps them to saving time and also remove the subjectivity. So this was also studied at Nanavati Hospital, and where Dr. Natarajan performed this study and identified that digital interpretation has 40% better interpretability versus the paper-based reading of the graphs. The solution also got a good response in the government hospitals, where central monitoring was also required, where they have multiple beds and required multiple number of NST machines. So looking at each and every bed was difficult, so they wanted it to be on a central system. So it brought an additional convenience to the doctors. Last component from my end. So during COVID, one of the challenge that was faced with mothers were isolated, and particularly high-risk pregnant women who were in other case visiting every week or twice a week to the hospitals and facilities. It has become a challenge. So requirement came from the doctors only, can we offer you a fetal monitor at home for NST? And that was a great point for us to also contribute during COVID. And I'm also very happy to share that Dr. Hema Divakar's clinic was one of the first hospital in Bangalore during COVID times to start this activity, where the solutions are offered at mother's place at home. They perform the test at home and they share the report with the doctor and receive the remote consultation. So there were few incidences with some of the hospitals where high-risk mothers or COVID positive mother faced fetal heart irregularities, and the final conclusion was basically, as per the doctor's opinion, the tests were performed again at hospital, and then mother was taken for C-section, and ultimately an intrauterine death was saved. So those kind of stories started coming up. So in nutshell, throughout our journey, we of course learned a lot with doctors, nurses, policymakers, and our common conclusion is basically digital health can bring convenience and access. How it fits to the system, can we scale it, are some of the very important questions, and we are still figuring out the solutions for it. Although we have also started reaching out to other countries, and we are getting very good response from countries like Nigeria, Bangladesh, Afghanistan. We really want to see that we scale very much in India as well. So that's it from me. Thank you very much.
Thank you, Shantanu. The best praise from IIT Mumbai being put into the best use for the mother care in this great country. And your video especially, it just reflects on the fact that women in India, whether she lives or not, depends on where she lives to go through her pregnancy and delivery, a risky journey. So that is what it's all about, reaching the care where it is needed. And we are very thankful. Rajni, who I can see here, Bhartiji, Vani, myself, who have consistently for 9 months put the programs together, say 9 months are up, it's time to deliver. And digital solutions, the way forward as it so the very, very exciting journeys that you have taken us through. And we know that everything at the start would not have been easy at all. But the fact that this platform has brought great insights to each one of us for further collaborations to sustain and scale these very initiatives which you have started, shared your lessons with us, and together we can and we will is what we would always like to say on e-dialogues brought to you by ICMR, NIN, and UNICEF and all the other collaborators. So thanks on my personal behalf, also to the 8 brilliant panelists that we had today. There is a lot to chew, lot to reflect on, and a lot more to do. Thanks a lot. Rajni, over to you for the conclusion.
Thank you. Today's program featured a number of thought-provoking presentations and debates. We are grateful to all of the outstanding speakers and panelists. We are convinced that our participants learned a great deal today. We appreciate all of the participants' enthusiastic participation and, in the polling and in the questions. Join us for our upcoming e-dialogue, which we will announce shortly. Have a great weekend. See you all in the next e-dialogue. Thank you.